Good afternoon, everyone. My name is Sarah Taysir Ben Sharif, and I'm an EU health reporter based here in Brussels, as well as a practicing physician. It's my pleasure to be your host today and to welcome you all to what is sure to be a fantastic event on an issue that is ever more important: antimicrobial resistance, and specifically, how to talk about it. I mean, even just saying it, antimicrobial resistance. It's a mouthful, isn't it? But before we dive right in, I just have a few housekeeping notes to get through. I know many of you in the audience are already itching to ask questions on this topic already. Please rest assured, we've set aside some time at the end of the first panel and at the end of the second panel to take questions from the audience. Please send us your questions by using the Q&A tab on the right side of your screen. And if you want your question to be directed to a specific speaker, please just let us know. And just to give you a quick heads up, we'll be asking you some questions over on Slido to hear your thoughts and ideas. So please log on there at slido.com with the QR code or the event code using your laptop or your phone. And lastly, we do encourage you to post about this event on social media. And if you do, please use the hashtag antimicrobial resistance. So we're all gathered here today because we all want to learn about how to better communicate about antimicrobial resistance. But really, what's at stake here? Well, for one, antimicrobial resistance is happening at a wildly accelerated pace. And we know that that's mainly through the misuse and the overuse of antimicrobials in humans, animals, and plants. Drug resistance makes it really difficult and sometimes even impossible to treat certain infections. As a doctor, I see this all too often, whether it's patients with urine infections that aren't treatable with the most common antibiotics, or the frequent conversations about why an antibiotic isn't the answer to a viral illness. Advocating for the effective use of antibiotics isn't always an easy conversation I have with patients. But the reason we need to figure out how to better talk about AMR is this reality. These superbugs that have learned to dodge our best available medicines are killing people. Now, here's a staggering figure from a key study in The Lancet. In 2019 alone, bacterial AMR was directly responsible for, get this, 1.27 million deaths worldwide, and it contributed to nearly 5 million deaths. To put it bluntly, AMR is killing people. It's also an incredibly costly problem. In the EU alone, AMR costs around 1.5 billion euros every year in healthcare costs and productivity losses. It's a lot to take in, but thankfully it's not all grim news. There are growing efforts to tackle the issue, with experts calling for a One Health approach. It's one that recognizes the links between human health, animal health, and the environment. Because ultimately, addressing AMR isn't just about doctors and patients using antibiotics wisely. It's also about managing antimicrobial use in farmed animals and in our agri-food systems, for example. So it really is essential that we take the full picture into consideration when we talk about AMR and when we try to raise public awareness about AMR. We already have initiatives whose goal is to contribute to the general public's understanding of AMR. There are events like the World Health Organization's AMR Awareness Week and the European Antibiotic Awareness Day, but there's still more to be done to better communicate on this issue. So on that note, today you'll be hearing from our fantastic speakers about exactly that: how to explain such a complex issue clearly, how to get information to the intended audiences, and how to motivate people to change their behavior. So now, without further ado, let me introduce our first set of speakers. We are joined by Stefan Bushusha. Stefan is an associate professor and the associate head of school in the School of Nursing and Midwifery at the Faculty of Health at Deakin University in Australia. Stefan's research program is dedicated to infection prevention and control, commonly shortened to IPC, with a focus on antimicrobial stewardship and determinants of IPC adherence behaviors. Welcome, Stefan.
Thank you, Sarah Taysir.
I'd like to extend a warm welcome to Anna Heblu, registered nurse, public health expert, and director of REACT Europe. Anna has extensive experience working in humanitarian crises, both in refugee and migrant crises, nutritional emergencies, and outbreaks. Thank you for being with us, Anna.
Thank you.
And last and certainly not least, we are joined by Mark Mendelson. Mark is director of the Trinity Challenge on AMR and a professor of infectious diseases at the University of Cape Town in South Africa. He led the development of South Africa's antimicrobial resistance strategic framework, and he chaired the Ministerial Advisory Committee from its inception in 2014 until 2023. Thank you so much for joining us, Mark.
Thank you very much.
Great. So now we're going to zoom in on Stefan. We're going to kick off with your presentation because you're here to talk to us about AMR media representation. So Stefan, the floor is yours.
Thank you very much, and thank you for the invitation. I want to acknowledge my co-authors on this study, which is Professor Megan Jen Johnson and Emma Whatman. Next. So I'm talking to you from Melbourne in Australia, and I just wanted to start by acknowledging the Wurundjeri people of the Kulin Nation, who are the traditional custodian of the unceded land on which I'm speaking from tonight, and I pay my respect to their elders past and present. Next. So this study was supported by the Early Career Grant from the Australian College for Infection Prevention Control. And as a disclaimer, I am the current president of the Australian College for Infection Prevention Control, but I wasn't at the time the grant was awarded, and I don't have anything else to report. Next. So we all seen headlines on media, and this is just a collection from the last few years, with my favorite one being in the middle, the mop of death, which really kind of conveys some the media are using different ways to convey information to the general public, and it is an essential part of our communication program. So I wanted to have a look at how we framed antimicrobial resistance in Australia in the media. And next, in the context of the WHO warning in 2014, where we were entering a post-antibiotic era, that was also underscored in the UK in a report tackling drug-resistant infection, which estimated that in 2050 we'll have around 10 million people could be killed, but it's probably an underestimate from the figures that we have now. In Australia, the first antimicrobial resistance strategy was published in 2015 and described the issues as a looming public health issues. And next, please. And we need, as Taysia was saying, we need a whole of society response to combat that. And we traditionally use mass media to have an active role in informing public health emergency, and obviously that role can shape public perception. Understanding the responses can lead to what's called moral panic sometimes, and still tell us that a lot of the time these mass media depictions are not true, but they are at best partial truth, and sometimes they may even feel like collection of lies. So we were really interested in looking at what was presented in relation to antimicrobial resistance in Australia at a certain period of time. Next. And we've used media and in infectious disease a lot. It allows people to be exposed to a large population, to be exposed to health promotion messages, potential to change behavior through emotional and cognitive response, and we'll hear more about that. I think potential, but there's also potential to bias the risk perception with things like called unrealistic optimism, sense of threat and uncontrollability as well, that can heighten the risk perception. Next. And it also can influence policy. For example, in the UK, an episode of EastEnders in the late 80s led to an increase in condom sales and record number of calls to a national AIDS helpline, and also can lead to distrust and skepticism. And we've also seen that with the media coverage of HIV and AIDS at the beginning, which was found to be universally distorted and led to stigmatization. So it's very important to look at what is done in the media with regard to antimicrobial resistance. And if you go to the next, please. we know that framing is a key issue in the media, and it's the framing enable the presentation of complex issues efficiently, but it also has that potential to lead to misinformation and stereotyping. Next, please. So in this study, we really looked at two questions. Are we being prepared by this representation, and what is the media capability to prepare us, and how are behavior influenced by this, or potentially influenced by what we're seeing? And we had 4 research questions for this study. If we go to the next slide, which was, what attention has the media given to the issue of AMR since WHO first started issuing warnings about the problem? What policy documents have been devised by Infection Prevention and Control Authority to guide media response to the AMR issue? What frames have been used by the media when covering the AMR issue? And also, are there any potential risk and benefits to the public of media coverage? So really, next, please. We were looking at an unobtrusive qualitative research inquiry. We looked at discourse analysis, philosophical inquiry, and looking at the data analyzed using a framework designed for this study. We sampled this data from 6 databases. And next, please. With key terms, as you can see here on the left, such as AMR, so we had really broad key terms to try to capture everything, and we sampled from January 2022 to February 2017, so as you can see, before COVID, and we found there was 3 things really. We found that overall the reporting in the Australian media was balanced and well informed. There were some human interest stories, so to add power, and also the frame that was used was really the content and the conceptual metaphors. Then this was used in creative ways to inform the media headlines, but also the content of the report. We made the conclusion that the reporting was balanced and well informed because a lot of the article referred key figures in public health and scientists, and also you know the when looking at the number of reports, which is on the next slide, please. Looking at the number of reports, there was some positive, negative, so it was really spread quite widely. So we found that there was really a steady increase in the reports, with some sporadic increases, especially when there was some patient death, but there was no sustained increase to that. So there were the increase to frame a certain clinical incident, and then it was coming back to baseline. In Australia, we found that AMR wasn't a political issue, and the only political party that mentioned AMR were the Victorian Greens, so one of the states in Australia, which were calling for a CDC, and that was in 2010, and the CDC is being started in 2024, so it's taken 14 years for that to come through. Next slide, please. We found really that there were 6 key metaphors that were consistently used to communicate information about AMR, and I'm going to talk a little bit about each of these in a little bit of detail. So superbug metaphor, military, criminal, epidemic, doomsday, and then the othering or blaming other metaphor. So if we go to the next slide, please. So the superbug was the most common used, and obviously it took a superbug being superbug being the term coined to look at this resistant microorganism, and it become a metaphor in itself. And you can see some example of this in the top right corner. We started talking about superbug in 1985, and really looking at 3 things. It's super powerful, super intelligent and sentient, and super sneaky frame. So really 3 aspects to the superbug, and it's really all-encompassing, overwhelming, can outsmart us, outwit us. It's sentient, intelligent, so it has a living. It lives on its own. It has taken it is sentient. So next slide, please. Military, which has been used a lot in medicine, and I think we'll hear more about that a bit later, really evoking anxiety and emphasize the need to enter a battle to counteract the resistance menace. The next slide. We also had the antimicrobial resistance depicted as a criminal, so that overlaps a little bit with military, but also anxiety provoking and kind of lurking in as a lurking killer lurking killer that's ready to pounce as soon as our guard is down. So that's really quite silent and in the background, waiting for a vulnerability. Next slide, please. Epidemic, which is not surprising, it's an unstoppable menace that is non-discriminatory, seen as collective calamity in this thing, and used to represent conditions, but not contagious in this case. So antibiotic crisis hit high, super catastrophe risk as antibiotic fell, and so on. So really looking at this thing that is we cannot stop. Next slide. So we also did see some impending sense of doom. So this is the end. This is death is inevitable. This is going to happen, and we can't stop it. So we cannot stop this bug. We going to return to the dark ages. There's an apocalypse, and we're all going to succumb to that. So really powerful metaphor with really this anxiety provoking. And it kind of did see that this gave rise to what we term creative desperation, where we're trying any single substance to try to counteract the threat of antimicrobial resistance. And I think I've read things like platypus milk and all sort of. That's when we start talking about the certain honey, and all sort of things that scientists are trying to counteract the effect of antimicrobial resistance. It also feeds in a theory which is called the terror management theory, which frame death as one of the main motivators of what we're doing. And I think that's quite an interesting perspective. And next slides, please. And then one that was really interesting is the othering metaphor, and I think this comes also. I think it's we can also frame that in looking at the terror management theory in terms of that when I taking antibiotics, it's fine because I really need them, but the problem is the other person. I know that my neighbor, they're always on antibiotics. So it kind of allows us to minimize the seriousness of the issue, because we kind of say, oh yes, for me it's fine, but for my neighbors, yeah, they're overusing it, or for the person down the road. In the print media, it was interesting that the blame was apportion a lot to medical practitioners and Australian government, to travelers, other countries. So everything that's not us, not taking responsibility for that. The TVs and documentaries were more reticent to use blaming other metaphor, except when in Australia directed to certain countries. And India, for example, was described as a superbugs petri dish. So next slide, please. And so really some interesting frames were found in this, and we did find that it was fair and balanced. Used a lot of case studies to highlight impact on the individual, so making it more tangible to people, not an issue that couldn't affect us. There's been also a steady increase in the coverage. We couldn't identify any events, political campaign, except when some serious events like this were reported, and they were often reported as case studies, and as again that allow people to identify to that. Othering as a form of denial to enable people to minimize the seriousness of the public health issue. As I said, we can absolve ourselves from responsibility because I know that I'm doing the right thing, or I know that I'm giving my child the antibiotic because they're really, really sick. And we have seen othering a lot lately since COVID. Again, since we've seen othering re-emerged with COVID-19, but it happened with SARS when SARS was framed as something from another country in the majority of places, and COVID as well. So there's this thing that we don't want to take responsibility. And next slide, please. And really, I mean, we realize that this is really a small piece of work that we've done, but we really, as healthcare workers, have a responsibility to inform patients on risk AMR is posing. And really, for us as a healthcare worker, and for anybody having an understanding of how media represent the AMR issue can foster collaboration, but there's really is a need for specific communication guidelines on AMR and media to make sure that we continue to have a fair, balanced representation, and that we know what we're trying to achieve with working with the media. And it's going further than that. How can we use metaphors to affect behavior changes? How can we do that in an effective way rather than being sensational? For obviously the media have the aim of selling papers or selling news or online. So really, it's working together, and that's why these communication guidelines would be really essential to achieve that. Next, thank you. I think that's it for me. Thank you very much.
Thank you so much for that really excellent presentation, Stefan. I see that I fell for that very popular superbug metaphor right up in my intro, so maybe I should review that in my analogies. You've given me a lot to think about. And we'll touch on many of your points, I'm sure, during the Q&A. So a quick reminder to our audience, please send us your questions in the Q&A section on the right side of your screen. And with that, I thank you, Stefan, and we'll touch base again during the Q&A.
Thank you.
Now it's time to hear from Anna. Hi, Anna.
Hi.
You're going to be telling us all about language and community engagement in communicating on AMR. So Anna, the virtual microphone is all yours. Take it away.
Thank you so much, and thanks for having me here this afternoon or morning, evening, depending on where people are in the world. So yeah, I will be talking a little bit about React's work and what we have learned from over the years around communicating on AMR. And first of all, React as a network was initiated to be a catalyst for change and stimulating for global engagement around antibiotic resistance. And this through collaborating with a broad range of organizations, stakeholders, decision makers, individuals. And we want to drive change both through local interventions in communities, in healthcare sector or other sectors, creating bottoms-up approaches, and also by supporting implementation of national action plans, and also through policy dialogue, and both like in the 4 regions that you can see on the map here where we work, but also jointly together on global level. So I'm based in the university in the Department of Medical Science in Uppsala. And here also we actually focusing on some antibiotic smart projects in Sweden together with authorities here. But the main parts of our work is taking part in the React Latin America, React Africa, and React Asia Pacific. And being a network who both is working on community level and driving policy, we need to be attentive to how language works, both when talking with people in communities, in societies, in different parts, of the world, and to decision makers who also sometimes don't know so much about the problem that we are wanting to address. And therefore, like the discussion on language and how to communicate and what do's and don'ts have been there from the start. And just this 2 days ago, an article was published by our founder, Professor Otto Kars, also stating that the language on antimicrobial and antibiotic resistance is blocking global collective action. And this is a little bit what we touched upon already, that also the use of words, the mixing of terminology, and the very medicalized and very technical language around antibiotic resistance. From React, we are framing the issue more of like the vision is a world free from untreatable infections, which we think is very good to focus on the healthy part of it and where we're aiming at, rather than focusing on resistance as such. And we also often argue and raise that we want to ensure sustainable and equitable access to effective antibiotics. So that's more what we talk about rather than focusing on resistance as such. But since we're also based in different parts of the world, we are then have created very much like different approaches to this that we've learned from. So I'm just going to mention 3 examples here, and you can put the next slide on. Next slide, please. Yes. First example is from React in Latin America that has worked with empowering communities initiatives since many years back. Here, the colleagues in React Latin America, they very early actually abandoned this war metaphors that we heard about from Stefan previously, and talked much more about actually balance. And with their approach of like reimagining resistance, they also actually wanted to talk about how like a deepened understanding of the world of microbes, which is like there around us, and that are invisible and fascinating, and actually can be a quite positive, narrative to move forward. And this was, of course, like very much linked and rooted in local culture, and also adding on there a right to health approach and communicating on that. So very much on the healthy side. Another feature that it's often like not raised among us working with antibiotic resistance is, to use arts and use other ways of communicating rather than just language, fact, and information. And this is something that have been done through the network in React Latin America. And I will come back a little bit to an example in the end. So we can put the next slide on. Here we have an example from React Africa, where colleagues there have over several years worked both with engaging with health promotion, similar to what we have done in different part of the global health response. And the entry point have often been to reach communities that has some leverage in communities, so church and faith-based organization and healthcare providers, and also now lately really using a gender lens in how to involve communities. And it is very much about a dialogue, not to come with clear-cut, ready-used messaging, but to involve women here, as you see on the picture, in Motivator Hospital in Zambia, and in explaining their stories, their relations to health, their experiences, and their across there that way understanding what the need of antibiotics, but also the need of preserving them and using them wisely. So those have been, and some of these work has also been to like active activities together, a lot in the WASH area, which has also been done by the teams in Kenya. So next slide and next example. Yes, here we have the team from React Asia Pacific, also who have worked another way of engaging local communities. And here it has been really to try to identify on very local level in the smallest unity in the state of Kerala, a way of actually using through dialogue, coming to identify what kind of activities do the community wants to pilot that could have a positive impact of on the effectiveness of antibiotics. So it started off with very much ironing down what is important here, and these included, that a need of training of farmers in how important they could make their products become, and also demonstrating compost and pits for waste disposal, and also even local campaigns against non-prescription use of antibiotics. From there, it was an indicator framework that was developed that could then point to show antibiotic smartness at a community level. What REACT picked up from this kind of project was the need of actually not entering with discussing antibiotics to start with, but to again come back to what is important at local level, what kind of activities could be important to people there, and talk about other health needs. And of course, there it really made the project become very much focusing on preventive measures, IPC, WASH, and so forth. So, and there's been several articles that the team has published on this, and also lately now a handbook. And the project is being piloted by the teams in REACT in Indonesia, and also we hope to be able to disseminate the ways of working to other groups as well. Now we can put the next slide. Yes. Also, we have engaged as a network in trying to come together to define what works and what doesn't work when it comes to community-wide engagement on antibiotic resistance. So last year we held a workshop here in Uppsala, gathering different groups from communities and academia to try to learn from best practices in this field. And a lot was brought back to, the way how to formulate, how to create a narrative that worked around antibiotic resistance in community level. And I think the insights were there that there's no one size fits all, but that this really is context dependent as well. But that narratives that were more positive and that was also focusing on, healthcare more in general was also more easy to formulate and get across. And also, of course, that in order to do so, that cannot come from top down, but really has to be identified together at the group level. And now we can take the next slide. Yes. So there's also several initiatives on communication from communities to leaders. And one of these examples that we've seen is, how communities can play a role in changing the course or creating more political action behind the words for interventions against antibiotic resistance. Here we have on the slide one initiative that is very recent now from REACT Latin America and PAHU, who for several years had a community declaration, Empowered Communities Initiative. This initiative we're now making global. So the ambition is to have a call for action ready in the coming weeks, that we will gather sign-ons from communities and civil societies organization across the globe, that we will then be able to put forward to decision makers before UNGA so that's mid-September. We, in this call, has actually really, React and Power only facilitators here. So there is a text being out on now for consultation, where you can really feel that the language is there. It's an actual language of change that the communities urge member states to include their voices and their needs in AMR governance structures going forward, and to actually request more equal representation in the work going forward, and more youth representation, and that global action needs to happen now. So in 22nd of April, we're launching this online globally, but it will already be out there from April 7th in Argentina. And it's one example on communication from communities to political leaders to act on AMR now. And I think from all of this, what we are very eager to listen into are the other discussions and actually innovative way to get across the issue from communities on that are moving away a little bit from the jargon and the technical language. And just want to, before I end, to point that behind me I have this pyramid of health. It's again about talking, instead of the resistance, talking about the infections and the healthcare services that are actually leaning on having, the access to effective antibiotics. And that is one way of getting away from needing to categorize between different medical terminology, but really to see that, infections are part of, human beings' lives. We all somewhere on this pyramid, as newborns or elderly or in everything in the beginning, and will then need to have access to effective antibiotics is something that is important for all. Thank you very much, and I'm looking forward to the discussions coming after this.
Thank you so much, Anna, for your presentation. You really highlighted how it's important to work directly with communities to find the unique ways of addressing AMR that are really particular to their context. So thank you so much for covering all of that. For our audience, we've already covered a lot of ground. So just a heads up that if you want to revisit this great conversation and event, the recording will be available on the ECDC's YouTube channel. So stay tuned for that. And so thank you, Anna. And with that, we will be turning our attention over to Mark Mendelsohn. His presentation is intriguingly called War and Peace. And I have a feeling this isn't about Tolstoy's novel of the same name. So I'm quite curious to learn more. So Mark, the floor is yours.
Sarah, thank you very much indeed. And thank you to the organisers for the honour of speaking today at this very interesting webinar. And I've chosen my topic, this issue about the framing of antimicrobial resistance. My talk really is specifically about antibiotic resistance in bacteria and the issues around using the war rhetoric. I have no conflicts of interest that would make this talk problematic. Next slide, please. So if you look at the literature, if you look at images that are available, overridingly, there is a description of antibiotic resistance and a war against bacteria. War is declared, but in fact, as I'm going to show you, I feel that this is not a war at all. It's the wrong analogy. Also, if you really did want to wage a war to mitigate antibiotic resistance, the war is actually on humans, not on bacteria, because it is we that are increasing the use of antibiotics across the One Health spectrum, and it is down to us actually to change, not the bacteria. But war is a problem. Next slide, please, because you reap what you sow. When you attack bacteria with antibiotics, when you fight, then the more antibiotics you use, the greater the amount of resistance will develop. And this is just one example of a number of resistance enzymes, beta-lactamases, enzymes which render the bacteria resistant to the action of antibiotics increases as antibiotic use has increased across the years. Next slide, please. And I think one of the problems with the war rhetoric and the use of war and fight is that there is a difference which is not recognized between what the fight really is, I suppose, which is a call to action, and the fight in a war situation, a military type fight with aggression. And so, yes, we need to use call to action and we need to use language around it, but we don't need to bring in the war analogy. Next slide, please. In fact, there are many communities across the world who are deemed non-warring social systems, social communities who have made specific moves to not recognize war and to not go to war. And indeed, in the state of global peace, of course, it's heterogeneous, but there are a large amount of countries that actually don't think of war and think far more on a peaceful existence. Next slide, please. Furthermore, war is a deeply patriarchal construct. This dated, somewhat graphic of an advertisement for teaspoons that the wife is meant to have ready for her soldier as he comes home. It's the man that fights, the woman does not, which of course we know is not the case anymore. But it is a deeply patriarchal construct, and therefore, for many, is actually off-putting as a construct. Next slide, please. I also feel that war and peace are indeed themselves metaphors for research and development for new antibiotics versus infection and prevention. And indeed, the majority of financing in the antibiotic and antimicrobial resistance space actually goes to basic research and therapeutics of new antibiotics in which to attack, fight, or however you like to think of it, bacteria. Now, of course, R&D is important, and of course, we need antibiotics to treat people with bacterial infections. But on the other hand, peace I see as much more in the realms of infection prevention, in preventing the need for this arsenal of antibiotics that we are trying to produce. And I think if peace was given more of a chance, it figures more with an increase in infection prevention, which I would argue is actually where at least half the world, if not more, requires the intervention rather than new antibiotic research and development. Next slide. So I think we need to change the narrative. We need to change the narrative from war to peace. Next slide, please. Because as you know, we humans are symbionts. In other words, we live in a direct relationship, predominantly with bacteria. We know now a little bit more accurately what the ratio of bacteria to human cells in the body is. But we still, even after this study, we know that bacteria outnumber the amount of human cells. So we are symbionts and we have an interest in not attacking bacteria. Next slide, please. Because those bacteria, particularly those in our colon, have extremely critical roles to our wellness. And those include competing out bacteria and other microbes that can cause disease. They're critical in our digestion and metabolism. A key point is that they are critical to not only gut immunity, but the immune response in the rest of the body. And also, we know now more than ever the importance of the bacteria in your gut in relation to determining the gut-brain axis and the effects on the central nervous system and cognitive function and mental health via multiple mechanisms. And so it's in our interests to maintain our gut microbial population, and particularly our bacteria. Next slide, please. Indeed, health, this picture shows these lovely pie charts are all different types of bacteria different parts of the body. So in and on our body are bacteria in almost every area. And the diversity of those bacteria are generally related to health. The less diverse, once antibiotics are given, or indeed many other factors. Of course, antibiotics are not the only thing that affect our gut microbes, but antibiotics are a key issue in causing alterations in those microbes. And that can cause disease and problems. Next slide, please. And there are now really strong associations between a number of states, disease states and other, linking antibiotic exposure. One of those is obesity. So the gut microbes are impacted obviously by genetic and environmental factors, some of them being antibiotics. And gut microbes play a critical role in our energy absorption, our appetite, how we store fat, and also our circadian rhythms. And indeed, in animal human experiments, if you give an obese mouse the gut microbes of a lean mouse, they become lean, and vice versa. And indeed, if you transplant the microbes from the gut of an obese person into a mouse, then that mouse becomes obese. So there is clearly a obesity profile of the microbes in humans. And we also know that particularly within the first 2 years of life, children who get antibiotics are more likely to have obesity, and that increases as the number of antibiotic courses continues. Next slide, please. Similarly, it's not just obesity, but in fact, there are a very large number now of conditions, including overweightness and obesity, but also allergic conditions such as asthma and allergic rhinitis, celiac disease, and indeed neuropsychiatric issues and neurological issues such as ADHD that are associated with antibiotic use, particularly early in life. And the more antibiotics you use as a dose-response relationship, so the more antibiotics you use, the more likely you are to have that. Next slide, please. And lastly, of the diseases that are linked to antibiotic use, we know that inflammatory bowel disease, both in ulcerative colitis and Crohn's disease, increases after antibiotic use, usually within the first 1 to 2 years. This study of over 6 million people in Denmark showed this. And as you can see from the graphs, these purple lines are becoming further and further to the right, which means that with more and more courses, you increase your risk. Next slide, please. So there's very definite associations between the use of antibiotics and disease states. It's not just about resistance. And so instead of going to war on bacteria, maybe it's time that we actually turned our attention and narrative to peace. And that would increase the amount of narratives, the scope of narratives, and the engagement of stakeholders. Next slide, please. And as Anna mentioned, one of the key issues is around access. So sustainable access rather than resistance is much more a positive message than just trying to talk about resistance and disease states. And access is important because, as we heard earlier, 1.27 million deaths per year in 2019 from attributable resistance bacteria, and 5 million resistant associated deaths. But overall, there are around 8.8 million deaths from bacterial infections per year. So that means that non-resistant bacterial infections make up almost 4 million deaths, and they are being caused predominantly by a lack of access to antibiotics. And so if we reframe the situation from talking about negative resistance to a sustainable access, that's an opportunity. Next slide, please. I never thought I'd present a slide in a talk with Gwyneth Paltrow on it or any of these influencers and wellness gurus, but it follows that there may be an enormous opportunity to get messaging across around wellness and our microbial population that we live in symbiosis with, and how important that is, rather than strengthening the narrative around wellness, rather than strengthening the narrative about deaths, morbidity, and resistance. And so with Goop, for example, with over, I think, 12 million people getting these their newsletters, these sort of people could become important stakeholders. Next slide, please. And then again, almost to finish, as we've heard both from Stefan and from Anna, positive messaging is incredibly important in your change behavior. So moving away from discussions on resistance, morbidity and death to positive wellness and the benefits of our symbiotic relationship with bacteria actually are positive messages which could be used to strengthen our case. Next slide. So I would put to you that everything we know suggests that war rhetoric fails to change behavior, in this case, antibiotic-related behavior. We saw it also being used during COVID, and in fact, almost every major health crisis. But there is a difference between a call to action, which we should celebrate and get everybody involved, and understanding that it's not about enemies so much and fighting, it's about wellness and preserving our symbiotic relationship with bacteria. So I think it's time to give peace a chance. Thanks very much.
Thank you so much, Mark, for your great presentation. I really didn't expect that to take a stand to make peace with bacteria, but you certainly made a really great case for it. And I really didn't expect Gwyneth Paltrow and Goop to make it into a presentation on communicating on AMR, but it was really, really great. Thank you so much. And with that, we now move on to our first Q&A. So a reminder to our audience to please submit your questions on the right-hand side tab, the Q&A tab. And we'll start by asking your excellent questions to our speakers, but at the end, the tables will turn, and we will be asking you, the audience, some questions through Slido, so do stay tuned for that. So I'm just going through the questions that have come in. There's a bunch of excellent ones. It's really hard to choose where to start, but perhaps I'll start with this question from Balaji to Stefan. Balaji asks you, Stefan, how much of such news from the media reach the people with less access to media, or those who purposefully keep themselves away from the media? And how do we approach such people to create awareness? Great question.
Thank you. It is a great question, and it's a question that the answer has probably changed a lot over the last few years because of the way people are consuming media now. So I think it is about we could never ensure that everybody is tapped to the media reach, the news reach everybody. So that's always difficult. It's about leveraging the new media, the social media space, these kind of things, and making sure we move as well with the way the media is moving to reach the people that are relevant in this issue. I think.
Sounds like it's not very easy.
No, I don't think so.
Thank you very much for that answer. The next question is over to you, Mark. So it's a question from Karina. Karina asks, how can we foster a transition of understanding our relationship with microbes as two species cohabitating rather than fighting against each other? You know, that war metaphor that you spoke about. How can we foster that?
I think it starts from the very bottom up. I mean, it starts with how we educate from school level and the messaging we give all the way through to continuing professional education and trying to understand also for the public an understanding of this wellness issue. The fact that we usually say, well, you can't have an antibiotic because you've got a viral infection. It's not enough. You have to, obviously it takes time to explain to people why they can't. And you mentioned that, Sarah, in your introduction, how many times you've had to fight that fight, as it were. Excuse me, now using fight as a as a word. I shouldn't be doing that. So balance, yeah. But I mean, I think the narrative, I think we have to accept that the narrative currently is not working. I mean, we haven't been through the discussion of antimicrobial resistance as an appalling term and that we shouldn't be using it. We are still using it purely, I would suggest, because of political reasons, that at a level now there is a kind of investment in the term, but there's no point in there being high-level political buy-in for a term if nobody who is a behaviour actually has to change understands and accepts it as an issue. I think it's far more interesting to start thinking about how one can have positive messaging around your relationship with bacteria and how important they are to you, not to damage them, and rather than the sort of resistance idea.
That segues really nicely into a question we have for Anna. You mentioned, Mark, that the term antimicrobial resistance is not a great term, and I called it right from the get-go a mouthful. It's a lot to get out to explain a concept to a general audience. So the next question is for you, Anna. What would you say are the main challenges in the current language used to talk about AMR, and in what way can we change it?
Okay, I think, I came into this area just two years ago, having worked with like humanitarian and global health, but not specifically on antibiotic resistance. And I just realized that we were talking about AMR from day one, an abbreviation, but what we meant was antibiotic resistance. And I think this is where also like it's a bit of a danger when you start to compare like apples and pears, and what you actually do come up with is misinformation at some point when we do use these terms interchangeably. So I think the first thing we can do is to make sure that we know what we include. And that's where I see that like in scientific community, in the policy community, we even now start to talk about bacterial AMR. That is maybe not so helpful neither always, although like for people having worked a little bit with the topic, then you start to understand both the logic of it and at least it's clear. And I think, so that's one problem. And then there's a lot of other lingo like antimicrobial stewardship. That doesn't say much to anyone, not even all like people with a nursing or medical background knows what it is before you have like entered, the course on infectious diseases and that specialization maybe. So there is maybe just a need to think of rephrasing some of this and explain, at least when we go out to public, not take for granted that people understand what we talk about. And I think for how we can change it is, I think we need to actually include other experts than the medical ones. Definitely to rephrase this, we need people, used for like communication strategists. We need social sciences, and I think there is a momentum actually moving forward with this. I think that's one part, and then also maybe it is linked to what we talked about, rephrasing this from something that is focusing on resistance to focusing on health. But I'm also a little bit interested in what we said about the last slide there from Mark on like healthy. I
think on my end, Anna has frozen. Yep. All right. We'll bring her back in as soon as we can, but I'll use this to transition back to you, Mark. You mentioned political will, and this year there's going to be the high-level meeting on antimicrobial resistance during the United Nations General Assembly. I'm just wondering, do you think this is going to create momentum to change? Like, is this kind of high-level political will going to generate the momentum needed to change the language around AMR?
I'd like to think so. I think what it will do, is give highlight antibiotic resistance as the main issue, and therefore hopefully will generate further work. And I think one of the main things that we're calling for towards the political declaration is an independent scientific panel that will be set up to really, understand and guide research. And of course, language is part of that research agenda and behavior change. I mean, AMR, antimicrobial resistance, has missed the beat with the lack of social science until more recently. It hasn't been given the predominant importance that it needs. So I think from that point of view, yes. I don't think that the political declaration is going to contain an issue around language. And again, as I said, because of the high level sort of political buy-in of the term antimicrobial resistance and AMR, that's not going to change. I think what UNGA will do is provide an important opportunity, particularly for groups working in community engagement and also in language and community engagement, to showcase work potentially at the side events. But I think that to put it on the main agenda is probably unlikely to be possible.
Thank you for that answer. Really appreciate it. And welcome back, Anna. So we have a question here from Eva for Stefan. And Eva's asking, since you looked at such a long period of time, did you see some trends in narratives or framings along the years? Like, how did things evolve? And I'll add my little follow-up question on that. Given that we've just been in a pandemic where we've been talking about a bug, a virus, and we've been talking a lot about antivirals and bacteria and antibiotics and superimposed infections and what have you. How has that narrative changed at all before COVID, during COVID, and since?
Thank you. I think we didn't see too much change. It was fairly consistent in the use and the constant use, and especially the othering the military, as Mark was saying as well, which is quite consistent into the metaphor that were used in the period we look at. So we stopped in 2017, so obviously much before COVID. In terms of so I think these 5 or 6 metaphors that we found, really if looking at it now with that frame, looking at the way COVID has been pictured, they're pretty much the same thing as well, with the war metaphor, the criminal, the war, the killer lurking in the shadows. It's the other people fault, I'm doing the right thing, and we've seen that a lot during COVID, especially attributing the disease to another country. It's the fault of these people, not us, and not really trying to apportion that blame to somebody else, which is really quite present in the antimicrobial resistance. So I think if you look at which we did a little bit looking at the COVID literature from the beginning, you can see the changes as well in terms of at the beginning, and it was mostly othering, and then it changes to becoming a fight, becoming a war, and all this kind of thing. So there is an evolution that we didn't see with the antimicrobial resistance in the period we look at.
Thank you very much.
Answer the question.
No, that answers it very well. Thank you. I'm going to pivot down to, at least on my screen, it's bottom left corner, to Anna. Question from Balaji, who asks, did you categorize people from communities as having different levels of education, so people with a more basic education or healthcare professionals in a community, to understand better ways to work with them? And if so, what kind of terminologies are used to explain AMR to various kinds of individuals?
I mean, the different initiatives have been taking place in different settings. So, for example, like colleagues have interacted a lot with communities like on village level, then they are together in one group. So no differentiating there. But there's also like programs towards children, in both in Ecuador and Brazil, that is also engaging with all children then, but of course then in a very insightful way of really talking about what we hear about, bacteria as actually our friends and something to live in balance with, but also using, really easy techniques of, getting children to understand differences between viruses and bacteria. So it's more been like intervention towards different groups. And another group then are students, both students in university who are in medical degree or medical education program, or other students as well. So it's more been like group per group. So, and I think different ways then of explaining has been used depending on the groups. But also listening into what is the pre-understanding from the groups before coming with, the information and the lecture.
Yeah, there's a lot to be said about health literacy and how much that plays into how we communicate about AMR or about any health topic for that matter. Absolutely. This next question is from Christophe to Mark. Christophe says, pardon me, I understand the need to change the frame, war being also inaccurate, but more specifically, have you in mind the evidence-based negative impacts of the war frame on people's risk perception?
I think there are. Yeah, I think there are certainly from the COVID literature. There was a study done actually in South Africa in KZN around war rhetoric in COVID, which showed that there were more negative perceptions around war, around COVID when you used that. If I'm right in thinking, I think there are examples, but I can't quote them off the top of my head. But it's an interesting question.
Yeah.
I can just add on, if we think of, oh, sorry.
No, please.
Mark, go ahead.
No, go.
Okay, Anna, and then we'll circle back
to
you, Mark.
Anna. I think Anna's frozen again.
It's frozen again, yeah. All right, Mark, back to you.
No, I'm interested by that. There's an awful, on the counter side, there's an awful lot of literature around behavior change and positive messaging. But I'm not a behavior change expert, and I can't quote the studies. Maybe Stefan.
Stefan, sounds like you have something to add.
No, I think it's the anxiety-provoking aspect of these metaphors that can sometimes bring the opposite effect. So it doesn't force people into action. It actually stops people from changing because of the anxiety that is around. So it's kind of inaction, some of it.
Fair. I'd like to ask one last question before we move on to the next segment, but it's a question that goes to each of you. So we'll start with Anna, if you can answer this question. So the question for all of you is, what do you think about the general use of the word prudent when it comes to our conversations about AMR? Doesn't it risk to push healthcare professionals to be prudent at the expense of those who really need antimicrobials? Should we not instead talk about appropriate use or different kind of wording? I think Anna's frozen again, so I am going to circle back to Stefan.
I think that's an interesting aspect, because it's when looking at the statistic that Mark presented in terms of the people dying from infections, there's quite a lot of people dying. So it looks at access rather. So the prudent is probably not the right thing. It's the appropriate, but it's also how you increase the access for the people that need these antibiotics to get them. I think that is this really important aspect.
Mark?
I think that everybody has their favorites in this. There's prudent, responsible, rational, appropriate. We've written about this before. I think prudence, firstly, prudent is a term that's often used in the veterinary side more than in human. Prudent use of antimicrobials is quite an important issue in veterinary medicine. Prudence to me often also, prudent in a financial sense, which has different connotations. Rational is wrong because I don't think irrational is the right. So it's not just the term; it's its opposite. Irrational. All of these things are very much context specific, and that's the problem. It might not be rational for somebody in the UK to get an antibiotic over the counter and just take them themselves. Whereas if you're in a rural, low middle income country where there's no access to healthcare and you've got a vendor on the corner who has an antibiotic and your kid is sick, you're going to be very hard pushed to say that's irrational. Personally, I use appropriate. I think appropriate is a good term because it's fairly, it doesn't have quite the connotations that some of the others do. But it's horses for courses, and actually it's the idea behind it and the context that's important.
Absolutely. Anna, last word to you before we move on to the Slido questions to the audience. You want me, I can go over the question. Oh, I think we have frozen once again. So with that, let's move our attention over to Slido. Thank you both, Mark and Stefan, for your excellent answers, your excellent presentations, and we're excited to have you if you're available for the final round of questions at the end. So audience, please do send us more of your excellent questions. So now we want to hear what you think. So please get your phones out or use the browser on your computers and go to slido.com. Use the code 1321513. It's up there on the screen, and answer the following questions. And just as a heads up, you can submit the questions more than once. So the first question is, what are the terms connected to antimicrobial resistance that are the most difficult to understand? So I'm excited to see what you all think. I certainly have my mind that I find a little bit tricky to wrap my mind around. So let's see, maybe some of you will find the word superbug I used in the intro a little bit triggering. Antimicrobial, antibiotic, absolutely. What else is coming up? Oh, I see that there's answers coming in. Oh, that's our event code. Sometimes I find the term multi-drug resistance tricky because it's hard to know how many drugs constitute multi-drug resistance. Superbug, yuck. All right, noted. One Health, interesting. Definitely a topic that is spurs conversation. I see prudent, AMR, stewardship. Lots of good terms. Keep them coming. Keep them coming. Appropriate use, inherited resistance. The word appropriate use has come up a couple times. Okay. One Health definitely is gaining some traction there. Stewardship. Microbe, absolutely. MRSA, CRE and CPE, MDR. Lots of good stuff there. And drug resistance. Yes, absolutely. That's one of the terms that can definitely cause a bit of confusion. So it certainly looks like the top terms that are causing, that are a bit more difficult to understand are antimicrobial stewardship and stewardship, similar lens there. One Health, resistance, and appropriate use. And there's a few on the multi-drug resistance. And I see a few people who are who don't love the word superbug and find it difficult to understand, which I can absolutely understand. All right, a few more seconds to get a few more answers in. IPC, absolutely. Infection prevention and control, what does that really mean? Dissemination, we see superbug again. Integrated surveillance, definitely a complex term and a complex process. Resistance is coming up again, which is important since we're talking about how to communicate about that very topic. All right. Silent pandemic. Interesting. Yes. It's definitely one of the tropes that's used to discuss AMR. I see associated deaths. Yep. XDR. Prudent has come up again. Lots of great terms for us to clarify and for us to be aware that they aren't necessarily the easiest to understand and can be really difficult and essential to clarify. All right, we'll be moving on shortly to the next question, but it really looks like the main themes that are the most difficult to understand are One Health, stewardship, and specifically antimicrobial stewardship. Next question, we want to hear from you. What are the most common barriers beyond wording to communicating on AMR? So what are some of the common barriers beyond wording to communicating on AMR? Is it jargon, unnecessary use? So we want to hear about what is the trickiest part to communicating on AMR? Is it reaching the audiences? Is it clarifying topics and themes? Is it using jargon-free text? So we see the economic case for AMR, the associated deaths related to AMR. We see public awareness is really tricky to do, communicating on eradication, HAI, associated deaths is coming up a lot. Political interest, absolutely, that's definitely a tricky thing. The lack of awareness is definitely difficult as well. The complexity of the matter, the different backgrounds, monitoring. I see misconceptions, absolutely, too technical jargon. That's definitely something that AMR suffers from, and science in general, when we try to communicate about it to the general public. Health literacy is coming up a lot, and absolutely something that is a big struggle. And unnecessary use, community engagement. Absolutely, we had Anna's presentation on that, so hopefully you walk away with a few gems from that presentation as well. We have jargon, public awareness. So it really looks like some of the top barriers beyond wording to communicating on AMR are the jargon, which is kind of related to the wording, but it's how do we make it clearer? Health literacy, which is fundamental, of course, to making sure that people are on the same page and actually understanding what we're trying to communicate. Patients expecting treatment, yep. The associated deaths is a tricky thing to communicate. Public awareness is a difficult one to address. Keep them coming. You guys are doing amazing. Health literacy is popping up right there. Complexity as well. Those are the two big terms I see on my screen there. Patients expecting treatment. Yep. Political interest. Yep. We definitely mentioned that in our questions with the first set of speakers. All right. Illiteracy, definitely important to consider. Misconceptions, patient-doctor dialogue, the medical personnel, how do we communicate about that? It's too scary, someone wrote. Yep, definitely need to be aware that AMR is scary, and how do we communicate about it without, making people panic, but also enticing behavior changes. Specialists, yep, time. That's definitely a tricky thing as a concept to convey. Lack of data, that's an interesting one. Alternatives to antibiotics. All right. So it's really come down to three things: jargon, health literacy, and complexity from what I see here. Yeah, if you agree with any of them, keep typing them in because it will really show us what everyone in the audience really thinks. Political interest, yep. Public interest, very interesting, yep. Do people really care about this? We obviously all think they should, but how do we impart the importance of the matter effectively? Great. Accountability, that was a good one too. All right, next question. What are the positive messages and narratives that could benefit communication efforts around antimicrobial resistance? What are the positive messages and narratives that could benefit communication efforts around antimicrobial resistance? Ooh, competing crises, evidence-based. Keep them coming. Traceability and community engagement. Preventing rather than mending, an ounce of prevention, absolutely. The One Health approach. The importance of protecting the microbiome. Past achievements, how far we've already come. Increased health, securing a better future for our kids, absolutely. Individual and collective agency. Bacteria are not the enemy, we learned that today. Collaboration, cost savings, absolutely. how to live healthily, that there's still time. It's not all doom and gloom. This is a win-win situation. We can also use patient stories to impart positive narratives. Proper use increases AMR. Maybe I misread. The One Health approach, accurate and precise information. You guys have so many. Control your own health. We do it together. Protecting the microbiome. Yep, we want our kids to have access to antibiotics. We want to have sustainable aging and health. We want to protect our access to efficient antibiotics. Healthy microbiomes coming up again, absolutely. Wellness of the gut. Return on investment, definitely. Bacteria are essential partners, definitely a theme from this first half of the event. I see patient stories a few times. Yep. The term using wisely. Yep. Protecting antibiotic effectiveness. Improved health is a big one that's come up a few times. Increased death from AMR. Human, I'm not sure I understood that one, but spreading health literacy, absolutely. Long-term strategy, we all have a role to play. Health for humans and also the environment. Lots of really good positive messaging out here. That's fantastic. Thank you. Keep it coming. Well, thank you very much, all of you, for your engagement and your fantastic, fantastic answers. I am really, really impressed. So we're going to keep all of those thoughts going for our next half of the presentation, which is all about targeting our, reaching our target audience. So all of these beautiful positive messages that you have all shared with us about how to communicate on AMR, well, how do we make sure that they actually reach our audiences? So we are now going to be welcoming our next set of speakers. So first, we are joined by Maren McKenna. So we'll just have Maren. Hello. So Maren is a journalist and author covering public health and global health. She is the author of the 2017 bestseller, Big Chicken, the incredible story of how antibiotics created modern agriculture and changed the way the world eats. And she'll be shedding light on how to explain AMR. Thank you for being with us, Maren.
Good morning. I hope you can hear me. I am so sorry. It seems like we have briefly lost my camera.
That's okay. I'm going to introduce the speakers,
yeah,
and then
I'm going to work. If you can introduce the other speakers, then I'll work on this for a moment.
Sounds great. Fantastic. So that's Maren. We'll be hearing from her all about how to explain AMR. So remember that first question we had on Slido about, the terms that are difficult? Well, Maren McKenna is going to give us lots of great tips on how to explain AMR. Next up, we'll be hearing after her from Claudio Brancelli. Claudio is a medical doctor and social media content creator who addresses lots of medical topics in an easily understandable way on platforms like Instagram and TikTok. And he will be sharing all about how to empower audiences through social media. Thank you for joining us, Claudio.
Good afternoon, everyone.
Great. And last but certainly not least, I'd like to extend a warm welcome to Diane Shader-Smith. Diane is a writer, speaker, publicist, and fundraiser. Just seeing if we have Diane. Diane will be joining us in it briefly, but just to tell you a little bit more about her before we get started with Maren's presentation. Diane's daughter Mallory died at the age of 25, and after that, Diane published Mallory's memoir, which is titled Salt in My Soul, and it led to a documentary of the same name. And Diane's going to be here to tell us about why all of this really, really matters by sharing the patient story. So we look forward to having her join us shortly. So to get us started, Maren, the floor is all yours.
Thanks so much for having me. And I'm sorry about that camera bobble, but it looks as though it's solved now. Too many inputs from my computer. So hi, everyone. I'm really pleased to join this gathering in what's morning for me, but afternoon or evening probably for many of you. As you heard, or as you can probably see on the site, I'm a journalist, author of several books. I'm a professor of science writing, and the problem of antimicrobial resistance and antibiotic resistance has been one of my main themes for probably 15 years now. I've written about drug resistance as a newspaper reporter, as a magazine writer, as a book author, and I've spoken about it in venues from here to the United Nations and the United States Congress. I did a TED Talk that has about 2 million views, and just a couple of weeks ago, I was at the South by Southwest Ideas Festival in the US. So I've spoken to a wide variety of audiences, from very professional to people who are very naive to the topic. And here are 3 things that have occurred to me. The first, I signed in a little bit early and I saw the discussion around the questions that were asked about what language to use. And it really thrilled me to see that, because that, I think, is one of the most important consistent challenges, is that as communicators, all of us, you in your professional lives, and even myself in my journalistic life, I just don't think we work hard enough to simplify complexity. Secondly, my impression is that we do not stop to think that many people all the time are coming to this topic for the first time. And the third is that we don't make enough use of what's a literally historic tool that's available to us for making our stories memorable to audiences, and that is focusing them on characters, on real people. And I'm going to talk now about these 3 points of mine. So I think that that those of you who are reflecting in the question that was asked at the end of the last session may already understand this, but the rest of you might be surprised at how many people have no idea what the word antimicrobial means. And yet those of you in the field and those of us who write about your issues sling the acronym AMR around all the time. I myself try never to use the word antimicrobial, because I see people's eyes just go blank when I utter it or write it. What we're doing when we do that is we are relying on what is effectively professional jargon, because those of us within the field understand it, and it's a shorthand for us. And we forget that people outside the field, the people whom we want to motivate to action, do not understand our terminology. I keep in mind that a few years ago, the British philanthropy, the Wellcome Trust, I don't know if there are any Wellcome Trust people attending today, recommended that people cease using the phrase antimicrobial resistance and switch instead to drug-resistant infections, because even though drug-resistant infections didn't express the whole universe of the problem of AMR, it was a phrase that's concrete and conveys an understandable threat. And I think that remains good advice, to be as concrete and as possible, and to avoid jargon as much as possible. So that's my first point. The second issue that I try to keep in mind is that when you are deeply immersed in a topic, particularly if it is a topic that you are passionate about and a topic that is your professional life, as a researcher or as an educator, it can be hard to remember how many people will be encountering this for the first time. I wrote my book, Big Chicken, which is called Plucked in most of the world, at a time when the EU had already tackled regulation around antibiotic use on farms in meat animals. And the United States was just beginning to tackle that. And once it was published, I went on tour about that book, or pretty much around the world, prepared to discuss all the intricacies of policy. And yet I found that when I was speaking to everyday people about it, I had to move way back in my discussions from the fine policy points to the very basics of antibiotic use in farm animals, and why that practice happened at all and what its history was. I was amazed the number of people who had never realized that this happened, even though it was an emerging issue in the United States and what we thought at the time was a settled issue in the EU as well. It's very frustrating, particularly I think when you are passionate about a topic, to operate at the level of having to always encounter people who are naive to the topic, because it feels as though you're never getting to the level where research is happening and where policy is being decided. But I do urge you to not forget that policy change requires an informed public. And to inform the public, you may always have to be going back to very basic concepts. So that's my second point. And here's my last one. The most important concept that I want to leave you with is to recognize that stories stick with us and motivate us to action when they are not primarily about policy. They're about people. That's what causes people to listen. Every plot that reoccurs in stories in all our languages and cultures, in fairy tales and children's stories, in novels, in bande dessinée, in movies, on streaming services, they're all centered on characters. That's what we remember. And we often don't remember the setting that they're in. We remember in English language storytelling that Sherlock Holmes was a fascinating, brilliant detective, but we probably don't remember in the first story in which he appears that it's woven into details of a polygamist sect in the Western United States. We remember that Oliver Twist was a very tragic orphan in Victorian London, but we probably don't remember what the laws were around public begging in London at the time, even though that's an important part of the topic. And to choose a more recent example, we remember that Luke Skywalker in Star Wars is a hidden boy with extraordinary talents. But unless we're really crazy about Star Wars, and some of you may be, we don't remember why he was hidden away. And there's a reason why we remember character-based stories. The researcher Paul Zak, who identified the action of the neurotransmitter oxytocin, wrote in 2015 that it's a reliable response that narrativizing a story, telling a character-based story with a timeline, evokes a physiological response. Evokes releases of oxytocin, the empathy hormone, and cortisol, the stress hormone. And what the release of those hormones does is to cause us to engage with a story emotionally. And because of that, we retain the story's content better. As far back as the 1960s, a pair of researchers called Gordon Bower and Michael Clark showed that we remember things better, even simple things such as lists of words, when we make up stories about them. So to me, narrativizing an issue of science moves the central question of a piece of communication from what did we discover, what was the problem, to what does this mean? How does it impact me, the listener? What is the lesson that I want to retain? So my final piece of advice about communicating AMR as much as possible is to make a story about it. Find a person whose experience can illuminate the policy question. This can be a victim who suffered tragically from a drug-resistant infection, or someone who was saved at the last minute. But it also can be a farmer who's struggling with how best to raise his animals, or a pharmacist who's frustrated because she's not able to dispense drugs that work appropriately, or even a politician who's very committed to the cause of reducing AMR. And I acknowledge that this is difficult. We journalists talk all the time about casting our stories in the same way that a movie director would find the right actors to embody their characters. And that can take a very long time. It is very challenging to find the right people to shape potent stories around. But the result is almost always that you end up with a story that strikes at people's hearts and that they remember and that moves them to action. I'll stop there. Thank you very much.
Thank you so much, Maren. That was really moving. And it's absolutely true that we remember character-based stories a lot more than just facts, facts, facts. So thank you so much for making that great presentation on that point. It's really essential to how we communicate on AMR to get people to remember why it all matters, people. Absolutely. So thank you so much. We'll circle back to you later during the Q&A and as well as during the roundtable. Next up, let's shift gears over to Claudio to hear what spaces like TikTok and Instagram have to do with communicating on AMR. So Claudio, on to you.
Okay, thank you. I'd like to thank the organization for the invitation. And I'm glad to be here today to talk about a topic I consider extremely important, empowering audiences through social media. Next, please. Let me introduce myself. I'm Dr. Claudio Brancelli, neurology resident at the Verona Hospital. And since 2020, I've also been involved as an healthcare content creator, aiming to use modern media to spread useful, reliable, and accessible information to everyone in the field of health. Next, please. Before I introduce the main topic, I believe it's essential to briefly reflect on the mass media that have characterized the media landscapes over the decades. Next, please. Newspapers, radio, cinema, theater, and television have... Next, please. Okay. So, mass media as newspapers, radio, cinema, theater, and television have played a crucial role in shaping our social and cultural interactions. These mediums have had a significant impact on society, influencing opinions, lifestyles, and even the cultural identity of entire communities. These were characterized by a predominant one-way communication model, where the audience received information without the possibility, in the majority of case, the possibility of direct interaction. Next, please. But now, today we find ourselves in a digital era where social media have taken on a predominant role. With social media, there is more interaction, transitioning from a mostly passive communication to a much more active one. They are platforms through which we share our lives, have fun, and seek information. It's precisely on this latter aspect that I want to focus our attention today. With the advent of the digital age, there has been a radical transformation in how we access information and interact with the media. Social media have revolutionized the media landscape, providing a platform through which to share, discuss, and access a wide range of content in real time. These digital tools have opened up new possibilities for connection and participation, allowing individuals to influence and be influenced by the culture and trends of the moment. Next, please. So it's true, it may seem simple, but there are many challenges associated with using social media as an informational tool. The risk of viral spread of content without adequate verification, manipulation, and misinformation from anonymous sources are just some of the challenges we must face. So we are thus faced with an eternal struggle between misinformation, what I called, next please, Mickey Mouse Journal and science based on evidence, but also communicating medical information to a general audience can be a complex challenge. Many medical pieces of information have complex concepts and a technical terminology that can be hard for the general public to grasp. Translating these concepts, it's more understandable. Language without sacrificing scientific accuracy can be a challenge. But it also depends on the type of communication and the target audience we aim to reach. And of course, medical information can evoke anxiety and concern among the public, especially if it talks to serious conditions or serious problems. It's important to communicate with empathy and reassurance, offering context and emotional support. Communicate with irony if possible, or through everyday life experiences, even in a light-hearted manner. Before creating content, we must elaborate on it, understand it, and recognize every single part that composes it. This way, we can touch upon every aspect of the topic. For instance, in 2020, I created a video where I discuss a common mistake when using antibiotics in a very ironic manner, specifically addressing the people who stop taking antibiotics when they start feeling better rather than when it's appropriate to do so. Next, please. In that case, the infection come back, and without ever mentioning it, also addresses the issue of antibiotic resistance. So another important point is how we can use social media responsibly and effectively to spread accurate and scientifically valid information. For example, introducing the feature of an healthcare professional on social media can be a significant step toward spreading reliable and accurate information. Moreover, by presenting data related to my work on social media, we can observe several important aspects. A community of people interested in what I share has developed over the years and not immediately. With around 40,000 followers on Instagram and about 170,000 followers on TikTok. And analyzing this data reveals several relevant aspects. Next, please. So, for example, looking at the age groups of my followers, it's clear that TikTok is primarily frequented by a younger audience. This shows that not all social media platforms are the same, and that's important to tailor content to the specific characteristics of each platform. Furthermore, it's important to consider the culture and the linguistic context of our followers. In my case, more than 95% of my followers are Italian, both on Instagram and TikTok. This aligns with my communication styles. All this brings us a fundamental point. When creating content or launching an awareness campaign, as in the case of antibiotic resistance, we must have a clear understanding who we want to target. Next, please. So, however, remember that each type of social media has its own peculiarities in terms of content and users, and it's essentials to take this into account when planning our communication strategies. Social media platforms with a younger audience, such as TikTok and Snapchat, are known to ease quick and immediate communication. On the other hand, platforms like Instagram, Facebook, and YouTube, which tend to attract older audience, allow more in-depth and reflective content, as the average user is willing to spend more time consuming the content. Furthermore, there are platforms like LinkedIn, which are particularly used by professionals and therefore favor content more oriented towards business and career. Finally, it's important to recognize that there are different types of social media used by everyone. This awareness helps us develop more targeted and effective communication strategies, adapting our messages and content formats to the features and the preferences of each platform audiences. Next, please. So additionally, I would like to take this opportunity provided by the ECDC, which I sincerely thank, to highlight another important aspect. Over the past 3 years, I've had the privilege of collaborating with the ECDC as an Italian advocate for the European Antibiotic Awareness Day. In 2021 and in 2022, I created and shared a series of posts on Instagram to raise awareness of this important issue. In 2021, I received a significant number of likes, while in 2022, although obtaining fewer likes, I was able to generate great engagement with my community, evidenced by an increase in interactions such as comments and post saves. So it's not important to focus on numbers of likes received. Our real mission is to educate, inform, and stimulate dialogue with those who follow us in order to achieve meaningful results in raising awareness on crucial topics like antibiotic resistance. And in 2023, next please. In 2023, we took a different approach, creating a video content that performed better This video was particularly well received on TikTok, where I recorded even more views and interaction, thanks also to the significantly larger number of followers compared to Instagram. This further leads us to reflect on the fact that nowadays the most direct and engaging way to communicate is through video content. This allows an effective message transmission and direct interaction with the audience, enabling us to create a lasting and meaningful impact. Another fundamental point is that we should not ignore the younger audience, because they are much more alert to certain issues, and also because they are the present and they will represent the future. Next, please. So the last point is how to address and improve the language used around antimicrobial resistance. Targeted marketing. Social media platforms offer advanced targeting tools that allow us to reach specific segments to the audience based on demographics, interests, online behaviors, and more. Number two, tailor messages to different audiences. Recognize that different audiences may have different levels of understanding and engagement with the issue of antimicrobial resistance. Number three, use clear and accessible language. Avoid medical and technical terms that may be unfamiliar and to the general public. Instead, use clear, simple language that is easy to understand for people of all educational levels and backgrounds. Number four, frame messages positively. Instead of focusing only on the negative consequences of antimicrobial resistance, such as increased mortality rates and healthcare costs, frame messages into a positive light by highlighting the benefits of a responsible antibiotic use, also personal benefits. For example, avoid side effects of the antibiotics. Number five, emphasize a personal and community responsibility. Encourage individuals to see themselves as a part of the solution to the antimicrobial resistance by emphasizing the role they can play in preserving the effectiveness of antibiotics through responsible use and infection prevention practices. Next, please. So, in conclusion, social media can reach anyone worldwide by using the right channels and distribution strategies. We can spread the antimicrobial resistance messages globally, reaching a wide range of people and communities. But it's important to carefully plan communication strategies, tailor messages for the audience-specific needs, and constantly monitor the effectiveness of campaigns to maximize impact and achieve positive outcomes. Thank you.
Thank you so much, Claudio. That was a really interesting presentation. Anecdotally, I've certainly seen that there's been more and more health providers using social media to share health information, especially since the coronavirus pandemic. So thank you for sharing your insights, especially on how to be specific with your specific audience and knowing that different users tend to use different social media platforms. That was a really great piece of insight. Thank you so much, and we'll come back to you during the Q&A. So to our audience, a quick reminder to keep sending us your questions on the platform using the Q&A tab on the right of your screen. We look forward to receiving all of your exciting questions. And now, last but certainly not least, we'll be hearing from Diane, who is going to tell us all about why all of this conversation really matters by sharing the patient's story. So Diane, it's a pleasure to have you with us. The floor is yours.
So I'm going to hide myself because I have a lot of slides. It sort of moves quickly, and I want you to look at the photos and listen to me and not look at me. So I'm going to put a little pink sticky over me, and I'm going to, do I do something, or is it going to tell me when you see my screen?
It's loading up shortly. We can see your screen. Thank you.
So you see a picture of Mallory?
Absolutely. She's beautiful.
Okay. Patient stories remind us that at the core of the AMR crisis are individuals, each with dreams, each with struggles, each with hope that there will be better solutions to combat this global health threat. My interest in all this started back in 1995 when I was a young working mom, happily married to Mark, and together we had two beautiful, kind, and lovable children, Micah and Mallory. You can imagine the heartbreak we felt when Mallory was diagnosed with cystic fibrosis. How do you tell your 3-year-old that she has a life-altering lung disease, that she will need to inhale multiple medications every day and have her chest pummeled by a machine hard enough to dislodge the sticky mucus that gets stuck in the lungs? There was no children's book back then to explain it, so I wrote one, Mallory's 65 Roses, because 65 roses is what kids hear when adults say cystic fibrosis. This book taught Mallory the power of narrative. Despite her diagnosis, Mallory had a happy childhood with no significant health challenges until she was colonized by Burkholderia caenosapacea, bacteria known for its resistance. Her doctor said that this would change the trajectory of her life. What I heard was that my daughter had an expiration date. Once Mallory understood that her bacteria might someday kill her, she started writing in this journal to process her feelings. These are her words. I didn't realize that my chance encounter with an opportunistic pathogen was like walking up to the devil's vending machine. I gave up my life as I knew it, and in return, I was left with the sinking and undeniable reality of my mortality, null and void, erased. Sapacea entered the microbial ecosystem of my lungs uninvited, waiting until my body was vulnerable to make its move. Microscopic armies of these bacterial cells then marched in and set up camp. During my first hospitalization at the start of 7th grade, my medical team came into my room to talk through the treatment plan after they had already started me on a cocktail of IVs. It would happen this way with each subsequent admission, routinely in this order. Cultures were taken, antibiotics were prescribed, drug susceptibility tests were performed, and then the cocktails were altered, which I have come to understand contributes to resistance. Faster diagnostics would have helped stave off this issue, another critical part of antibiotic stewardship, a word I learned today we shouldn't be using. To clear Mallory's mind of negative thinking, Mallory developed a mantra, live happy, and by outward appearances, she did just that. Mallory was family-oriented, she was a straight-A student, and 3-sport varsity athlete. Second half of her senior year in high school, Mallory got very sick, and of this time she writes, as the days wear on, I find myself panicking as I grow more oxygen dependent, experiencing pain with breathing, no longer able to walk without help. But outside of the hospital, life goes on. Even if I do get out in time for my prom, I won't be able to find a date. So I asked Rob Bowie, her water polo coach, who's pictured here, to see if he could help. And the next day, Dylan walked in with flowers, which motivated Mallory to work hard to get her strength back. It paid off. And to her surprise, she was voted prom queen. It was an incredible evening until the after party, when some idiot threw a smoke bomb into the venue. Mallory's throat started to burn. Her lungs were searing. Her eyes and her nose were watering. And then hemoptysis, when the airways bleed. Mallory writes of this experience, each time it happens, I wonder if this will be the time when the blood spilling up my lungs and out my mouth isn't just a scare, but the final, swift, deadly blow. Terrifying moments like this had distilled for Mallory a profound understanding of how precarious life was. It's why she felt the need to document everything, to collect the wisps, the threads of her untidy happenings. These are her words. As my bacteria becomes increasingly resistant, I grow decreasingly confident in the plans that I had etched in my mental map until it's hard to remember they were ever there. I am working very hard to see beauty in a life that looks quite different from the one I wanted, the one I expected. Mallory was finding her voice and she wanted to use it. In her high school graduation speech, she quotes the universally respected English philosopher Winnie the Pooh. I used to believe in forever, but forever was too good to be true. Words she chose for their relevance to her classmates, but that also had a private meaning, inspired by what she refers to as the dark voices in my head, the brokers of hopelessness. College presented new challenges, because after growing up with a helicopter mom, Mallory was ready to be on her own, but it was a really difficult transition. She writes about the duck syndrome, when you feel like you're a duck gliding on the water. What no one sees is that underneath you're paddling furiously. The stress of working to make things seem effortless creates a vicious cycle of silence and struggle. The crazy thing is that no one understood Mallory's distress because she still looked so healthy that everyone thought she was the golden girl who had it all. Mallory would have traded everything for the chance to take a breath that didn't hurt, to have a life that wasn't ravaged by resistant bacteria. Straddling the sick and the well worlds, Mallory did understand that amplifying patient voices could have implications for society, which is why she spent 10 years documenting what it was like to live with bacteria that was a known killer. 67 hospitalizations, ranging from weeks to months, led Mallory to write, "I am limited in what I can do, but not in what I can say. Resistant bacteria does a lot of taking, of dreams, of time, of travel, of friendships, of freedom, of potential, of plans, of lives. It's a complex, unpredictable, irreversible, progressive, painful, suffocating, choking weed. When I developed a fungal infection, things got even more complicated and emotionally traumatic. I used to have fun. I used to be fun. Now I'm afraid of everything, of being myself, but also of losing who I am. That the choices I make are going to cut my life short. I'm going to be on IVs for the rest of my life, and that is very hard on the liver. I'm afraid I won't be happy, that I won't have friends or find a significant other. Sex with a PICC line or an IV drip? Ugh. I am afraid I will always just be that sick girl. And yet Mallory persevered, graduating from Stanford Phi Beta Kappa, ready to take on the world. But doctors said she could not do the environmental field work she had studied for because it would further damage her lungs. Mallory was devastated, but realized she had to move on. She got hired to write a book, The Gottlieb Native Garden, a California love story. But working independently was lonely. So after that, Mallory interviewed for a writing job at a company with a lot of young employees. The company loved her writing sample submissions, and they made her an offer. But when she disclosed her medical condition, they withdrew it, even though she'd written her samples when she was in the hospital. Shortly after that, a lung function test led to a hospital admission. Once again, resistant bacteria interfered. Mallory was distraught, this time because she had to cancel a date with a guy she really liked. I said, invite him to the hospital. Why not find out if he could handle it? One very special nurse named Ashley Trueblood helped her get ready for her date. She washed her hair. She gave her a pedicure and a facial. This is in the ICU at UCLA. And she ran to the drugstore to get Mallory mascara. My daughter had a wonderful time on that date, even though Dave was not her person, and he's now happily married to a man, and they have a beautiful baby boy. As Mallory's body deteriorated, she sharpened her mind, crystallized her thinking, honed her writing skills, and hoped to find love. It was New Year's Eve 2015 when Mallory met Jack, who I called her real-life Prince Charming. They were having so much fun together, but then suddenly Mallory was back in the hospital. The antibiotics had stopped working, and the only option left was transplant. The approval that we finally got meant a cross-country move to UPMC because it was the only center willing to take on her complicated case. So Mallory had to say goodbye to everyone, knowing she might not make it back. This is us as we were getting ready to go to the airport. Mallory is hugging her brother Micah on the left. That day, there were oh so many tears. In Pittsburgh, Mallory struggled to breathe. She struggled to stay hopeful. She worried that her bacteria would kill her before new lungs arrived, that she would end up in the ICU clinging to life. If that happened, she writes, I want to be as comfortable as possible through opioids or anti-anxiety meds, but not be so out of it that I'm unconscious unless the pain is severe enough to necessitate that. I want to maintain dignity to whatever extent possible, to receive whatever life-saving tactic is appropriate, to be able to communicate in some way, to have the blinds open for natural light, to have calming music to listen to have my mom or dad with me always. I want to live. The call for lungs finally came, but it was a false alarm. And many months later, the fourth call was a go. Despite her fears, Mallory was so excited to receive the gift of life, new lungs. And the recovery was incredibly grueling. But 1 month later, Mallory was celebrating her 25th birthday without supplemental oxygen. It was the happiest time as we dared to dream about a new life. But just a few weeks later, that resistant bacteria we knew as Sypatia was back, and doctors said it was fully 100% resistant, that there were absolutely no more treatments. My husband, Mark, was not willing to accept that, and so he went in search of phage therapy. He reached out to epidemiologist Stephanie Strathy, who he had heard saved her husband from a superbug using phages. Stephanie tweeted for researchers to help, and it was during this period that the doctors told our friends to gather, our family to come, that it was the end. Because Mallory was on a ventilator, she scribbled this note, which reads, "Can't talk at all, but so grateful you are all here for the hardest part." I treasure this note. It was during this time that the United States Navy was quietly working on a treatment for an invisible enemy that they called Iraqibacter, resistant bacteria causing serious infections to military personnel wounded in battle. Herculean efforts enabled the United States Navy, Stephanie Strathy, and a few labs around the country, along with a small company called APT, to prepare and deliver a phage match for Mallory's isolate of Sypatia. That night, Mallory became the first patient in the US with cystic fibrosis to receive phage therapy under the FDA's compassionate use provision. The phages are in that white box on the left, and we were so hopeful and happy. But the very next morning, the doctor said that Mallory had been without oxygen for too long and advised us to make the gut-wrenching decision to remove life support. Saying goodbye to Mallory was impossible. But then the autopsy report came back revealing that the phages had started to work. Mallory just didn't get them in time. Mark could not save his daughter, but he was absolutely certain that phage therapy could save others, and that we desperately needed new treatments since antibiotics were running out. We shared Mallory's story with the media, urged the medical community to take a closer look at phages, and raised money to make the inaugural grant to IPATH, which is now leading the first ever NIH-funded trial using phage therapy. Meanwhile, Mark went dipping for phages in a sewage treatment plant. At this point, he was working with the Yale team to try to move things forward, while I worked with Random House to have Mallory's writings published posthumously as Salt in My Soul, which led to the documentary of the same name. Was it fate or divine intervention when the largest study to date about superbugs was published in The Lancet on the very same day the New York Times referred to Salt in My Soul as an awareness-raising tool about the possibilities of bacteriophages? At the same time, Forbes writer Judy Stone penned the headline, "Poignant Film Calls Attention to the Need for Phages for Antibiotic Resistance." The single most important thing I'll say today, when media and medicine align, there's an opportunity to amplify the message, to educate a broader audience, and to mobilize public and political will towards actionable change. Mallory gives voice to those battling resistant bacteria and fungal infections. Since she isn't here to use it, I do so on her behalf every chance I get at medical schools, conferences, corporations, community events, Capitol Hill, the White House, the UK, Australia, the European Commission, and NATO. I have given more than 250 talks to date, and what's shocking, and that I have heard here earlier today, is that most of the time that I speak to people, they have never heard of AMR, or if they have heard of it, they have no idea what it stands for. My theory, which many of you have probably heard or seen me post about on social media, is that it's because people are confused by the alphabet soup of acronyms that we use. World Health, AMR for antimicrobial resistance, CDC, AR for antibiotic resistance, DRI by the doctors for drug-resistant infections, DR colloquial for drug resistance, and the medical journals use MDR for multiply drug resistant. Oh, and of course, the lay public knows superbugs. Our brains need clear concepts to make sense of things. We need to use a singular term so people understand. Take cancer, for example. You say that word in any language and people get it, even though it refers to many different diseases at many different stages. The sense of urgency comes from being dangerously close to a post-antibiotic era. Kevin Outerson, the executive director of Carbex, and the man who taught me almost everything I know about AMR, says there is a way to fix this, that the science to address AMR is extraordinary, but the business model is broken. The good news is that because there's been a collapse in the drug development pipeline and a lack of state-of-the-art diagnostics, at the same time, superbugs are proving to be a formidable enemy. Many government, drug companies, and medical researchers are collaborating on a global revival of antibiotics, antifungals, phage therapy, and better diagnostics. But it's not enough. We need AMR to penetrate our consciousness. We need a worldwide aha moment where people understand just how many people will die or have died from AMR. To a patient like my daughter with a superbug, to a parent of a child suffering from resistant bacteria, to a healthcare provider trying to save the life of someone with AMR, there is nothing more important than finding treatments that will work against resistant bacteria, resistant fungal infections. Mallory was only 12 when AMR came for her and derailed her life. My daughter had so much to live for. There is a human death toll to the dearth of effective treatments and the dearth of targeted diagnostics that could help us preserve the current drugs in our arsenal. We think of lifespan in terms of human life, but antibiotics have a lifespan, which is why we need to be more careful with how we deploy them and how we speak about them and how we understand them. I had my own aha moment after speaking at the National Amputee Conference. I learned that amputees are at increased risk of bacterial infections, and it's the thing they worry most about. But at the same time, perfectly healthy people can get infections that lead to amputations. Take Tori Kinnaman, a gymnast at Duke, who contracted a superbug in the athletic setting and almost lost her life. And Katie Granger, a healthy woman who got sepsis from a simple cut and had to have her legs and her fingertips amputated. It's clear that no one is safe. As we mourn the many millions who have died or will die from AMR, it's important to think about patients and their stories as a way to raise awareness, because there is just so much that can be learned through the voices and experiences of people living with and dying from AMR, more so than through the details of a particular strain of bacteria. They are as diverse as they are misunderstood. Dr. Dominique Monet says that we need to educate the next generation about AMR to inspire future innovators to contribute to desperately needed solutions. To that end, Random House is publishing an adaptation of Salt in My Soul called Diary of a Dying Girl, with a clear focus on the physical and mental health challenges of living with resistant bacteria. What they are calling an eye-opening exploration of a global public health crisis told through the voice of a high school and then college student in language they can understand and relate to. It's the inspiration for the Global AMR Diary Project. We need collective storytelling to shift perspectives and shape policy, because we need to gather the stories of patients, families, healthcare professionals, pharmacists, researchers, all that will underscore the urgency of this crisis. And then we need to present these stories to those who are in a position to make the desperately needed changes. Exactly what Maren told us to do. By bringing these stories to life, we can trigger the transformation in perception that will make this crisis feel real and help people understand that deaths from AMR were and are preventable. Thank you.
Thank you so much for sharing yours and Mallory's story, Diane. It's really powerful and it really means a lot. And I'm very sorry for your loss. And thank you for using her experiences and your experience as a family as a pivotal moment for us all. Thank you. With that, we are now going to move on to our second Q&A. So we're going to have our three latest presenters. So Diane, Maren, and Claudio. And I'm sure our audience is brimming with questions. So a reminder to please submit them in the Q&A tab on the right. And then a reminder once again that we will be asking you, the audience, some questions at the end through Slido. So I'm going to start with you, Maren. It follows nicely from Diane's presentation and the importance of using stories. I mean, I can't think of another more salient example than what we just heard. So we have a question for you, Maren, from Eva. So she says, first, thank you for bringing the storytelling aspect of communication and how important it is for remembering things. Eva wanted to ask about using real stories versus fictional ones. Do you think that making up stories and characters also works in this context?
That is a really interesting question. I'll try to make this answer quick because I'm sure so many people have questions to ask. As a journalist, I don't write fiction, and I don't write fiction in the rest of my life either. I do not have the gene for writing fiction, but in my stories, I never fictionalize because, in my view, it is an essential part of the contract that journalists have with our public that we are telling true stories. Now, that doesn't mean that you can't anonymize a story if necessary. If someone has a particularly difficult experience with a drug-resistant infection, but for some reason can't be public with their identity, I think it's possible to anonymize stories. But the reality is that for most of us, unless we're actually clinicians deeply immersed in the topic, the fictional stories that we imagine are never going to be as real, as an actual non-fictional one. So I would recommend using true stories as much as possible.
Thank you for your answer. Anyone else want to add to that? I don't know if Diane or Claudio, you have any thoughts on that question?
I have a thought.
Yeah, Diane, go ahead.
So I think for smart, educated people, they're reading Maren's work. But I think there is a huge number of people who are not reading journalism, or they're reading fake news. And if they're watching Grey's Anatomy and they've embedded a storyline in, I think that is the way. So I don't discount anything that Maren said. I think she's absolutely spot on. But she's not. But to Claudio's point, you got to reach everybody, and you got to reach them in the way that they need to be reached. So for people who watch medical drama, if they can infuse storylines in there. I also, to contradict myself, I say nothing compares to real life drama in the medical world. Why would you ever make up a story when you can tell a real one? But I think you have to, as they say, fire on all cylinders and get it into nonfiction, true stories, and also entertainment media that some people are watching.
Absolutely.
I think that's a very fair comment, Diane.
Yeah. The next question we have is for Claudio. So Andreas asks, how do you conduct community management on your accounts when you have so many followers? You've got tens of thousands of people that you're sharing health information to. Do you respond to every question? How do you manage that balance?
It's not easy. It's not easy, of course.
My email inbox is already not easy.
Yeah. In my life, I'm also a doctor. And for me, that's the most beautiful thing in the world. And sharing and raising awareness on social media is something wonderful, but it takes a lot of time. And I already don't have much. So, however, I try to respond often to comments that can lead to interesting discussions, but my time is limited. So that's it's a particular question. Yeah, it's true. So this is the way I use my social media in my free time. So
you do what you can. That's all anyone can do. Yeah. This next question is from Becky, and I think maybe both Marin and Diane, you might be have some thoughts on this one. Becky asks, how do we tell a patient's story without scaring people too much, yet engaging them enough to feel motivated to take action? So it's kind of that analysis paralysis. If people are so scared that they can't fathom action, well, how do we strike that balance? How do we motivate them to feel, how do we speak to them to feel motivated to take action, even in a small way, to mitigate AMR without scaring them too much?
Diane, would you like to go first?
You go ahead, and then I'll go after you.
So this is an interesting and tricky question, because the reality is that that stories about scary diseases have a unique cultural fascination. Like we are so, at least in the West, I'm not going to speak for all cultures, but we are weirdly attracted to stories of outbreaks and epidemics and zombies and disasters. We find them alluring in a kind of monster under the bed sort of horror movie kind of quality, so long as they are far, the scenario is far away from us, right? So long as we know that there are not actually going to be zombies outside the door. I happen to live in Atlanta, where The Walking Dead was set. So the zombies is something, as well as the CDC, this is something I think about a lot. So the question then is, how do we make the storytelling vivid when it actually is something that people may be at personal risk of? And I think this is something that the whole field of AMR, here I am using the acronym that I told us not to use, has struggled with for years, because in this question of how do we create empathy with personal storytelling, people don't like to envision themselves being in an ICU or being elderly and confined to a nursing home that's having an outbreak. That is a thing that's a story that people will push away and not empathize with. So where do we strike the balance between this attractive, distant scenario that's sort of alluring to us and a close-in scenario that might happen that is threatening to us? I have if not a solution, then a suggestion, which is that as much as possible, I try to imagine who my most receptive reader or listener would be, who is not a policy person, who is not someone who just wants to hear a zombie story. I think about, what would I say if I were speaking to an intelligent 12-year-old? If I went home and sat next to a bright young cousin at a holiday meal. Imagine whatever holiday your family observes. Right now, it could be Iftar, and that bright 12-year-old asks you, "What is this thing AMR?" What would you say to them? What kind of story would you tell them? It probably wouldn't be overly frightening, because you don't want to scare a 12-year-old, but a 12-year-old is probably pretty able to receive fairly technical information. In fact, a lot of print media in the United States is written at the level of 6th grade, which is essentially 12 years old in our educational system. So I think about what I would say to that sort of imagined perfect reader for me, and that helps me tighter both the amount of technical information I want to give them and also the amount to which I can safely frighten them.
Okay, so I think it's a great question too. And what I found initially alarming, disturbing, and horrifying, but have now come to embrace, is that Random House and the agents working on Mallory's intellectual property wanted to change Salt in My Soul and the concept around that marketing to Diary of a Dying Girl. And the reason they decided to do that, and it took me 2 years to kind of come around to it, is because they felt it was important to convey a sense of urgency, that young girls, young women, young people tend to gravitate towards those stories. So back to Claudio's point, which it goes, it's going to come up a lot, know your audience. So again, I don't know that 60-year-old women, which is what I am, want to be scared and have any gratuitous fear mongering. But from what they tell me from all of their research, young people love stories of death and dying. That's what they're drawn to. So that is why they changed the title and asked me to come up with new entries and, repurpose it so that they could convey a sense of urgency. So do I think it's the right thing to do? I sort of say whatever works. I was asked to tell the patient's story, but a lot of times what I do speak about is communicating about AMR. And one of the things that I say, and I feel like I have to say it here, is that it doesn't actually matter what the word is. It doesn't matter what the term is. People say AMR. I think antimicrobial resistance is too much of a mouthful. But if you think of an Apple product, everybody knows Apple. It doesn't matter where you are in what country. You see that logo, you know it's either a computer, an iPad, a telephone, earbuds, whatever it is. That's sort of the thing about AMR. Whether it's AMR, whether it's Meshuggah, it doesn't really matter what the word is, as long as everybody in the world is using the same term. By that token, if you're going to think about true communications and dissemination of material, my background in publicity for many multi-decades is that you're supposed to be using the same language, and you're supposed to be using singular messaging, and you're supposed to do we're supposed to follow the example of KISS, keep it simple, stupid, which is to Marin's point that we communicate at a 6th grade level much of what we're doing, which is okay, because one of the reasons I did Mallory's 65 Roses and I still use it after all these years is because a picture is worth 1,000 words, and a couple words on a page with an image will communicate that point. So, if you show a dramatic image of somebody dying and you say, if you don't treat the cut on your finger, you may not make it. Some people might say that's too much information, but I feel like if we don't actually start to scare people, if we don't get people to understand that we're dangerously close to a post-antibiotic era, if we don't get people to understand that many millions of deaths that have been attributed to cancer, to HIV, to hip replacements, to simple cuts are actually the result of bacterial or fungal infections, I don't think we're going to move the needle. So I will end on saying, I think we have to come up with a term, and I think we have to scare people and make it seem real, because otherwise it's an amorphous threat that doesn't really inspire us to any sort of action.
Thank you both very much. Yeah, it still sounds like it's a difficult balance to strike between how much fear to illustrate the point, nonetheless. The next question we have is from Sideka to you, Claudio. So Sideka's question is, what are your suggestions on how organizations can engage social media influencers to support AMR awareness raising campaigns? How can we identify and reach out to the influencers who are doing the kind of work that you do on AMR?
So I believe that when creating awareness campaigns, as the antibiotic awareness campaign, it's always important to involve an healthcare professional, preferably one who is comfortable with the cameras, with the social media, because it feels more natural. And so to engage more people, you could also involve movie stars, politicians, especially on such an important topic as antibiotic resistance, which concerns each one of us. So I think this is one of the most important things. Healthcare professional must be in every kind of awareness campaign, for example, and most important in this case.
Thank you very much. Maren, I have a question for you that is from me, not from the audience, but you've written a book called Big Chicken, in which you delve into the introduction of antibiotics in the more modern agri-food system, specifically chickens, and how that feeds into AMR. There's a lot of science to untangle there, and I'm really curious to know, what did you, as a journalist and as an author, find most challenging to explain to your readers, and how did you overcome that challenge?
Oof. So we didn't prep this question in advance, so it takes me a bit by surprise. Let me see what I can say about this quickly. So Big Chicken, which is called Plucked in most of the rest of the world outside, I guess, North America, is the story of how we came to use antibiotics in meat animals from the beginning of the antibiotic era, how we discovered that was a terrible idea, and how a few places, notably the EU, particularly the Netherlands, and beginning in the United States, how policy was beginning to turn against that. So how chicken taught the rest of agriculture to misuse antibiotics, and how it was starting to reverse that historic mistake. And a thing that was particularly difficult about it, I think most of my readers, I think, found sort of the early history captivating, how scientists thought that they were doing a great thing, that they were feeding the world, that there were never going to be any downsides. We can see the hubris in that. That, I think, was not hard. What was difficult was, as the story expanded and expanded geographically, as more and more countries emerged into the economic condition where they could start to intensify their agriculture, was to be able to explain that this was in fact a global threat, that there were bacteria that were picking up resistance factors in India that were showing up in patients in Sweden, that the misuse of a particular antibiotic in agriculture in China was actually causing the National Health Service in the United Kingdom to start issuing bulletins about how this was moving across the world. In every chapter in Big Chicken or Plucked, I tried to tell a narrative of some person or some situation that people had identified, to make it real to people, and figuring out how many narratives there were across the world was something that took a lot of research to keep straight.
I can only imagine. Yeah. Thank you for your answer. Diane, I think you had a point you wanted to add.
It's actually to address something that Maren said earlier when she was giving her presentation, that, and it's actually a point that I feel really strongly about, and I have spoken publicly about it in so many forums to high-level people, and I'm just really happy that Maren said it today, because I think it is worth repeating, and that is that the scientists, the medical doctors, the researchers are not going to be the ones to solve the problem of raising awareness, that you really do have to bring in the storytellers, that you need to bring in Hollywood. Look, Maren says she's not a fiction writer. She's a storyteller who tells nonfiction stories. But the truth is, it's the same thing, right? Stories have arcs and they have dramatic builds. And, sometimes you take a real story and you fictionalize it. I used the word anonymize or something. I've never heard that term, but I know what you meant. But it does seem like the most important thing to do is to bring the people into the room who can take all the complicated topics, which is basically what Maren does for a living, and probably what Claudio does in social media, right? You're taking your information that you're trying to communicate and you're telling it through story. But in general, most of the times in these high-level meetings, you have World Health, CDC, researchers, scientists, data collectors, all these people who are the brightest minds in the world, but the way they communicate doesn't penetrate our consciousness. It doesn't make it stick. So I think that I think we all know by now that storytelling is the way to reach people. And to Maren's point, it's hard to get those people, but that's why we're starting this global AMR diary project, which may have to change the name if we don't stick with AMR. But if everybody in the world who had a story to contribute had a central place to do it, and doctors could have access to it, and politicians, and it could be used. And Maren, I'm going to be reaching out to you about that after. But I think that getting the storytellers to take all this information is really the way you're going to move the needle.
Absolutely. Thank you very much. We've got one last question for you, Claudio, before we go on to our roundtable, and then we will go on to the Slido questions to the audience. So, Claudio, we have a question from Carmine. So, how do you handle the negative comments on social media as someone who puts himself out there as a health communicator?
So, I don't know who made this question, but it's true. It's not easy.
No.
I believe there is the right way to respond when there are negative comments. Okay, if I understand the question, right, for the negative comments.
Yeah. How do you handle that?
I think is I believe there is not a right way to respond in this case. What I do is to take a moment and I avoid responding impulsively or aggressive. And I see if there are fake profiles, of course, no photo, no followers, nickname as a user 3456, and they are possibly trolls. In that case, I don't waste my time to respond that. But however, when I see well-constructed negative comments that indicate a willingness to engage in a dialogue, I respond clearly, sometimes even creating a response video with based on evidence. And some platforms permit that, as TikTok, and recently, if I'm not mistaken, also Instagram can permit it.
Can't be easy. Thank you for what you do, though. Thank you all very much for your thoughts and ideas and your stories. It was really, really appreciated and really great. It's now time to broaden the conversation to all of our available panelists. So we are going to be inviting the ones from the first half of the session back online. So we have Anna joining us, and I believe we will also have Mark. Perfect, great. So I have one starting question to get us going. So we've covered a lot of ground, and I'd love to hear from each of you, and I'll call on you individually, to hear what your most important takeaway from the conversation today has been. If you can summarize it for us as briefly as you can, but feel free to give us a little bit of meat, a little bit of juice. So perhaps I'll start with you, Mark. What was your most important takeaway?
Thank you. I mean, there have been so many, and what amazing talks from Diane, Claudio, and Maren. Thank you. Incredible. I think really probably the most important thing I've heard today is actually from Diane. Obviously, vast majority of what you said, but actually the issue of the ability to tell stories en masse. So people who are affected by AMR building a voice, because we talk often, again, this terrible term that few people probably really understand, civil society. It means many things to many different people. I mean, Anna, obviously we have civil society organizations. Many people think of them as the organizations that help governments, but I mean, to me, civil society are people, and we haven't been able to build that in the sort of bacterial resistance field yet. And I think that comes down to another issue, which we haven't really specifically spoke about, I guess, is the lack of the face for AMR. And I agree, Diane, if you have a term, if everybody's using it, that's great. But I mean, a lot of the terms, a lot of the illnesses and problems that we've seen in the past are so near to people because they know people who or have been suffering themselves. COVID and other recent events have shown that. And so to build not just one or two incredibly powerful voices like yours and a few others who are in the field, to actually build a true society of people who are affected, I think is very important and very powerful going forward to help in getting the narrative right and getting it across. Thanks.
Thank you very much, Mark. Maren, I know you have to leave us a little bit earlier, so I just want to move over to you. If you can tell us what your most important takeaway is from today's conversation.
So So first, I just want to say thank you for inviting me. This was both really fascinating to listen to and also just incredibly moving to hear Diane's story. And if I could not have set up, I could not have requested a more perfect illustration of my desire to hear personal storytelling about the impact of drug resistance than Mallory's story. And it's very clear in the comments from all the audiences watching this that they were similarly struck. The thing that I really, aside from this sort of base demand for storytelling, which is the water in which I swim as a journalist, the thing that I heard when I signed in to listen to the first panel, and that I think I heard from everyone in my panel, is how absolutely crucial it is to simplify our language, to bring this down to the level of people who are naive to the topic or who may be interested but really don't understand the terminology we use. And this, I would like to see this considered all the way up through the layers of national and international bodies who consider the impact of drug resistance. You know, I spend a lot of my time as a journalist reading international policy documents, and the UN and WHO's language is so hard that I can only take about 5 minutes of it at a time. And then I have to sort of blank my screen and think about it and go, you know, read a comic book or something to refresh my brain. The language that international policy setting uses is so impenetrable to the average person. And I think that trickles down through all the levels in which we're considering AMR. And I think a consideration of how crucial it is to get to plain language is something that we really ought to think about more.
Thank you very much. And I am going to use that to go over to Anna, since we're talking about language. So, and you gave us a great presentation on that. I want to know what your most important takeaway from this conversation is.
Thank you. And thank you so much for also, it was very, very interesting to follow the second panel. And sorry that I kind of, my internet broke down in the last session, but hope you can hear me now. I think I have many takeaways. I have to say that when I tried to read up on, you know, what communication strategies would work or not, there are some, I think what we land in here is like, there's not so many rights and wrong. There needs to be a diversity of approaches. I think what we have here, where, you know, the need of having, you know, medical healthcare staff to use their platforms and educate and also spread examples. I saw like an image on X some time ago on like, okay, a patient showed what this patient had been prescribed by presenting, you know, symptoms of cold, you know, and viral infections. So this kind of things also. And then also, of course, like the patient story, they're so important. We need to hear them many times, and people like you, Diane, they're really, really valuable. And also, when we think about how this needs to be relatable to people, the same goes for decision makers. They also need to hear the stories. They need to hear the clear examples. So it comes back to that we need, you know, the three, you know, good ingredients of communication and rhetorics. We need the good facts, the correct facts, and the terminology that is understandable. But we also need, you know, the different people bringing forward these stories with, you know, that relates, that are credible, and also that has something to say on the topic. And it needs to be, you know, speaking to people's minds and hearts somehow also. So I think that is what is needed, a diversity of things. And then also what I learned, one more thing also, is like, because when you read a little bit how debate is going, it is very much towards, we need to have a positive language. We need to have, you know, good examples. And I really subscribe to that. But I also think, you know, some it's good to be angry. Also, sometimes that can move things. That is really, really a crisis going on. And, you know, this issue, like a lot in global health, is about, you know, inequalities, that people are not accessing medicines that they should need, that there's not like, we have seen it in COVID, how rich country like hold on vaccines, and the same goes to like access to antibiotics. So I think we have the right also to be angry and to really have a call for action that is urging action also. So those are my takeaways, and thank you so much.
Thank you. I can hear the passion in your voice. It's very evident. Thank you very much for all of your answers so far. Claudio, what's your main takeaway from today?
What more can we say? I believe that everyone can contribute to this campaign, whether they use social media or not. Teach to other people, to general or professionals. Share stories, or each of us can contribute to the fight against this significant issue. So it's not important who we are. If I'm a doctor, if I'm not a doctor, we can share everyone in good way and in a simple way to the public. So I believe this is the most important thing.
Thank you very much. Diane, your main takeaway from today?
That I have to do what I wanted to do, which is use the launch of Mallory's diary book, where they're putting a lot of publicity and muscle towards it in the next month, to inspire people to share their stories so that we do have collective storytelling to shift perspectives and shape policy. That every time I speak, whether it's to 15-year-old boys in a public high school, or it's to researchers at the highest level, women in book clubs, it doesn't matter. At the end of the day, they are moved by stories. I feel like I've told my story so many times. How could there possibly be somebody that hasn't heard it? And every time I go, people are like, oh my God, what a story. They've never heard it before. It is a big world. There is, tentacles in every direction with people working, and we still have barely moved the needle in terms of people's awareness. And I do believe my takeaway is that I have to stick on this path, which is getting people to tell their stories. I did a panel in North Carolina that they set up with politicians when they were trying to pass the PASTEUR Act in the United States, which is the legislation that was designed to change the financial incentives to encourage drug companies to make more product. And I was on a panel with 5 people. I am a multi-decade marketing publicity person. My daughter left me a roadmap with language to speak about it. And she was deemed, they submitted it for Pulitzer Prize. Like, people think she's a great writer. Her story is no better or no worse than all the other people on the panel. The only difference was they didn't really know how to tell it. And there was a doctor on the panel who had the most interesting information, but she had a monotone voice, and she was slow to speak, and sort of as a down talker. And I thought to myself, okay, she needs coaching. She either needs to write it out and somebody needs to read it. And I think about Modern Love, the New York Times column, where people write these stories and then some famous person reads them and you're just so compelled to listen to them. And so I realized that we have to keep grooming people to share their stories in a way that will enable people to hear them. And some of those will be individual voices that can stand out. I mean, Mark, you talk about putting a face to it. When I spoke at the World AMR Congress, I said we need to put a face to AMR the way Tom Hanks did for diabetes, the way Michael J. Fox did for Parkinson's, the way Magic Johnson did for AIDS. But the single best example of all is Angelina Jolie with her BRCA announcement. Groups that have been working for 10 years to try to get people to understand what is BRCA, B-R-C-A, that acronym that was so impossible to learn. She made her announcement. Everybody knows what BRCA is. So we also need to bring in celebrity voices. And the number one thing I think we need to do is to get all of the highest powers that be together to agree that this is a priority, which then means you can go to Hollywood and say the World Health, the CDC, the British government, they all want you to make a little short film or to imbue this message into your storylines or to have more stories covered, in the newspaper. And it's not going to happen until it trickles down. That's my opinion.
Thank you very much for your answer. We have time for one more question before we pivot to Slido and some concluding remarks. So this question is for Julia. And and it's open to anyone who might have an answer to it, but I'm going to pick on Mark first. Julia asks, well, she says, she totally agrees that AMR wording is complicated and complex, and she's wondering, is there an easier wording that has potential to be used as effectively as the word cancer? When people say cancer, they automatically evoke an emotion, evoke a story. So she asks, do you have experience with just using, quote, resistance? And you're a professor of infectious disease, so I don't know how that sits with you, but yeah, I'm keen to hear what you think.
I think that I think it's very difficult. I mean, it's impossible even. Well, it's not impossible. I think from where I sit most of the time, we need to talk about things people actually understand and know immediately. So even shifting from antimicrobial to antibiotic, to me, that is, has always been the first issue. We need to talk about what we're actually talking about, and it is important, because when you talk about antimicrobial resistance and bringing everything else in, all the causes of resistance and the drivers of resistance and all the issues are different. And so, but in terms of terminology, drug-resistant infections, as Marion said, was put out there. It's not a bad term, but it only takes the infections. The whole point about it, of course, is that it's, as I tried to sort of explain, it's everything before that. I mean, what I was trying to say was really around how to prevent this happening, and then this second panel, I guess, was really about how we tackle it once this has happened. So that's a long way of getting round to it. It depends what you're actually trying to achieve. If you're trying to achieve people's understanding of the problem, you're trying to achieve action. And so to me, it's difficult because those two words might be different. The other thing is, I think you actually need to involve people on a grand scale to understand what resonates with them, because scientists, as has already been put out, healthcare professionals, we're not the ones that are going to be able to choose this word. It has to resonate with people. Thanks.
Absolutely. Thank you very much. I'm going to pick on you, Mara, next, if you have any other thoughts on this question, since you have written a whole book that deals with this. Well, how did you untangle this complex term?
So I much about this conversation that even though I was supposed to disconnect at 10:45, I've been watching the clock just to see what everybody else says. So let me say something quickly. I do agree that this is hard, right? That I mean, I try not to use the word antimicrobial, but in fact, most of the past couple of years, I've been writing about fungal diseases and the problem of antifungal resistance, which does not fall under the the umbrella of antibacterial resistance. So by not using antimicrobial, I make my own life more complicated. I'll just mention that a thing that Mark just said that I think is incredibly important is that we can't necessarily impose terminology from above, that we have to find something that makes sense to people. And I'm remembering that when the Wellcome Trust advanced the possibility of using drug-resistant infections instead of antimicrobial resistance a couple of years ago, I don't know if that's still their policy or if they've since moved away from this, but they actually held a bunch of focus groups to ask people, out of all the terminology we use for the problem of losing the power of antibiotics, which of these terms make most or least sense to you? And drug-resistant infections actually emerged in their conversations with everyday people as something that made sense in a way that AMR did not. And so how we do that, maybe Diane's diary project will help. Maybe we'll hear in that, maybe with the help of some large language models, what it is that people say when they talk about their own experience on a broad scale. That might be one use of AI that I could actually defend. I am so sorry that I now absolutely have to disconnect. Thank you all so much. Thanks to the audience.
Really appreciate it. I'm going to be a sneaky journalist and sneak one more question in, because that's what I love to do, ask questions before we go to Slido. So this is a great question from Erica that I'd be remiss not to ask. And Erica asks, how can we better involve AMR patients in developing communication materials? She writes that patient stories have a strong impact. as we've seen, when conveying messages effectively to the public and other patients. Also, AMR patients frequently express feelings of isolation in the development of communication materials or solutions through their perspectives. Could television commercials and radio help in this? What would you suggest? Maybe we'll take 1 or 2 quick comments on this. Maybe I'll pick on Diane.
Did you say my name or no?
If you have something you want to add, by all means.
Let Anna go first. I want to think for one moment. I have a thought and I want to let it ruminate.
Yeah. No, I just know that I think, no, this is a great idea because also like patient stories will also like help to explain, you know, the medical issue behind it. And I just think of a couple of good examples that Doctors Without Borders have done on their, they have like very good communications material that are really patient-centered also. And I wouldn't say it's so, I mean, if you just have the resources, like someone like you, Sarah, who's good at asking questions and collecting stories, write it up, make sure that it's like ethically done and that there's consent there and that there's someone also checking facts, because also, you know, sometimes actually stories will be, you know, a little bit misleading also if you don't have a medical eye on it. I just think you can use it as do it by blogs or just journals or in different ways. And I think there's sometimes perhaps also like a need of this from like a various of settings. Then I could think of a couple of like, ways that we from React have worked with this as well. So yeah, that would be, I think it's a good way to go about it.
Thank you very much.
Okay, I'm ready to answer. So one of the things I say when I go speak to patient groups, because every time I'm in a hospital setting or with patients, they want to tell their story. Mallory wanted to tell her story. Part of the reason, and it's different for different people at different stages, but when you have patients who are really at the end, they are fighting for their life, but they're not dead and they can't work. They're not able to do much, but they feel like their story is the one thing they have control over and they want to tell it. So what I say to them is, you don't have to be a good writer. You can do a social media post. You can weave together some fabrics from different moments of your hospital stays to create a quilt. You can take photographs of your journey. You can write a narrative. You can dictate into your voice memo. There are many, many ways to do it. I don't think that I would have undertaken to do a global project like this if I didn't have the backing of Random House and all the people that worked on the film and everything. And I am in a position to do it now. I have a full-time job. I don't need to work I don't have any financial, whatever the word is. I don't benefit financially because all the money from all the properties goes into a public 501c3 charity at the California Community Foundation. So I'm Switzerland when it comes to all that. And I'm able to, no, I mean, it makes a big difference. It actually makes a difference because when people think you're motivated by money, they trust they doubt your intentions. And when they know you're not benefiting. And the other thing is, it's funny because we have money, we've raised money and it's sitting in an account to use for AMR research. And you'd be surprised how hard it is to give money away when you have it, because there are so many obstacles to getting the information out there. So I think my long answer, which meant to be short, and I'm sorry I rambled, is that I would like to be in touch with each of you, and I would like to share the information. It's going to be, if it's done the way we envision it doing it, it's going to be accessible to everybody that has access to a computer. That's all they really need. And that way, because what I see now is PFID, the Partnership to Fight Infectious Disease, and CARBEX, all these different groups, they all have their patient stories. They all have things. It's not aggregated in one place. And what we need is one forum that is called the same thing, that is available to everybody with singular messaging. And I mean, this is exciting to me today because for the first time with Claudio and Marin on it, you actually have storytellers in the room. I mean, I'm usually the only one, and it's usually doctors and medical researchers and drug companies and people who are not in a position to actually do something. But you asked earlier what the single takeaway is. I want to leave with one final comment, which is that the single most important thing that this world of AMR people can do is to bring Hollywood in, because Hollywood could solve this problem in 5 minutes. If you get some celebrity that's big enough to say that there's a problem, and even if it's AMR and you don't spell it out, people will start to use it, people will start to adopt it, people will embed it into their storylines, and they will make it known. And if Hollywood pays attention, then journalists pay attention. And if journalists in Hollywood are talking about it, then you'll see it on social media. It's all interconnected. And so I urge the people who are in a position to move the needle to come together and agree that they have to look outside of the inner sanctum of professionals working to solve the problem and employ people. And I don't mean for money, I mean just engage people who are like me, pro bono, want to do this to help. There are a lot of people out there that are waiting, and they're waiting mostly because they know me. I live in LA and I work with Hollywood. But you know, it has to be that high level ask. My ending line at the AMR Congress was, if the right person with the right level of authority makes the right request, the answer will always be yes.
Well, thank you very much for that, Diane. That was very powerful again. I'm sorry I can't take any more comments from any of our other panelists.
Oh, sorry.
No, this was perfect. Perfect segue into our Slido. So I'd like to extend a virtual round of applause to all of our panelists for your time, your expertise, and for sharing your wisdom with us. It's really, really vital, and we are very thankful for it. So virtual round of applause to all of you, and hopefully we'll stay in touch. And to our audience, thank you very much for your questions. Now it's our time to ask you a couple of questions on Slido. So start getting your fingers ready to type. So the first question is, which communication channels do you think could help improve efforts to reach target audiences on AMR? So we have to use all of the channels, absolutely. Podcasts, that's a great one. LinkedIn, advertising in public spaces and public transit, totally. Advertising on streaming platforms, that's an interesting idea. Personal communications and activities in settings like preschools, schools, nursing homes, absolutely. TV and social media, yeah. So we're talking about communication channels that will help us to improve our communication and reach our target audiences. LinkedIn again, YouTube, lots of ads on YouTube for sure. Sounds like one of the doctor-patient discussions, Facebook, folk, theater, art, absolutely. TV morning channels, yeah, people having breakfast and learning about the news and other information, key information, definitely. Social media, TikTok, movies, social media and films, streaming platforms, TV's coming up a lot, Instagram, definitely, Netflix, LinkedIn, schools and educational institutions, podcast that has come up a couple of times. Social media influencers, Instagram, TV and social media, cartoons for children, that's an interesting one, okay. Netflix documentary, OTT, Disney Channel, hospital media influencers, every media showing. This is going so quickly, it's great. Movies based on real life stories. We've heard the importance of storytelling today for sure. Advertorials on TV, Twitter, or formerly Twitter, X. Has to be a mix of all of them, yep. Scientific events, schools at every age. We've had a few people mention schools. Games, that's an interesting one. Hadn't thought about that one. In the outdoors as well, absolutely. Gaming again. Animation, yep. Influencers has come up a few times. Fantastic, fantastic answers. So it sounds like pretty much as many platforms and as many channels as we can, really. So we're going to be moving shortly, i.e. now, to the next question. And this question asks, what needs to be done to move from awareness raising to behavioral change? That key last step when we're trying to communicate with people. A TED Talk, interesting. David Attenborough, whoever submitted that, I'm quite curious to know more about that. Gaming. So the question is asking what needs to happen to go from being aware of a problem to actually changing our behavior, whether that's our prescribing behavior, our farming behaviors, our consumer behaviors. So we see recommendations, mobile health apps, school presentations, an aggressive campaign that can perhaps motivate people to change their behavior, make them relate. Yeah, again, the power of stories, the power of, you know, the narrative. School presentations come up. All right. We have to tell stories, political campaign, political action plan, peer pressure, incentives for the public, showing real experiences. Again, this key concept of being mindful of stories, the importance of storytelling is really, really coming up often. Thank you all for your great insight. Policy making, mobile health apps, school presentation. Fantastic. Lots of great suggestions there. We have more awareness. We have showing real consequences, absolutely. Yep, those can all motivate behavioral changes. Well, thank you all for your fantastic answers to all of the Slido questions so far. So thank you for all your thoughtful answers. That brings today's event to an end. I'd like to once again thank all of our speakers for their time and expertise, and I'd like to thank the organizers of today's event, the European Centre for Disease Prevention and Control, and the European Commission's Directorate General for Health and Food Safety. And last but certainly not least, I want to thank each of you for your engagement, your questions, and your interest in this super important matter. I hope it's now clear just how big a threat antimicrobial resistance is, and why it's absolutely essential that we communicate about it as best we can. We hope you learn new strategies for how to talk about AMR that you'll carry with you moving forward. I know that I definitely will be taking some lessons into my own practice as a physician when I talk about it with my own patients. Now, before we let you go, we do want you to mark your calendars for the next European Antibiotic Awareness Day, which will be in November. So do stay tuned for more information on that. And with that, thank you all for your attention and your time, and I wish you all a fantastic rest of your day. Thank you.